Good afternoon, delegates. A warm welcome to all of you to the Cancer Awareness Program brought to you by Aster volunteers and Akcaf. I am Dr. Spetika on behalf of Aster volunteers would like to welcome all our Asterians and every delegate who's very specially joined us today. As you very well know, Aster volunteers has a singular vision to unite people from all walks of life in helping making the world a better place. In today's session, we will be talking about cancer in various forms by some distinguished doctors from different parts of the world who will bring to you their insights. With me, I have Ms. Anu, who is the founder of the Women's Wing of Akcaf and President. Would like her to please say a few words and welcome the gathering.
Thank you, Dr. Spetika. It is indeed our privilege and honor to partner with this healthcare giant, DM Healthcare, and we started our journey last year. Who are we? We are Akcaf, All Kerala Colleges Alumni Forum. We have close to 150 college alumni groups under our wing from Kerala. And what do we do? Well, we've done a whole lot of things over the past years, but something that is very close to our heart is what we are doing today. We started last year, February 19th, as a tribute to a very precious member of ours, Ahmed Ashraf, who passed away due to cancer. And we all believe that if it had been detected early, treated effectively, he could have been saved. And so we are on this journey to save more lives. I would like to invite Anup Anil Devan, the Chief Coordinator of Akcaf, to speak a little bit more about this. Anup.
Namaskaram. ക്യാൻസറിന് പ്രണയത്തെ തകർക്കാനാവില്ല, ക്യാൻസറിന് പ്രതീക്ഷകളെയും തകർക്കാനാവില്ല. മറിച്ച് ക്യാൻസറിന് ഒരിക്കലും നിങ്ങളുടെ ആവേശത്തിനെ കെടുത്താനാവില്ല. അതുകൊണ്ട് തന്നെ ക്യാൻസർ ഒരു ഉപദ്രവകാരിയാണ് എന്ന് നിങ്ങൾക്ക് തീർത്തു പറയാനാകുമോ? അവിടെ നിന്നാണ് അക്കാഫ് തുടങ്ങുന്നത്, അവിടെ നിന്നാണ് ആസ്റ്റർ തുടങ്ങുന്നത്. സ്നേഹമാണ്, കൂട്ടായ്മയാണ് അക്കാഫിന്റെ എല്ലാ കാലത്തെയും ലക്ഷ്യം. ആസ്റ്റർ എത്രയോ വർഷങ്ങളായി ഈ നാടിന്, മധ്യപൂർവ്വദേശത്തിന് മൊത്തമായി സാന്ത്വനത്തിന്റെ, സമാധാനത്തിന്റെ സന്ദേശം നൽകുന്നവരാണ്. നമ്മൾ ഒരുമിച്ച് ഇന്ന് സംസാരിക്കാൻ ഒരുങ്ങുന്നത് കേരളത്തിനെ, ഇന്ത്യയെ, ലോകത്തിനെ തന്നെ, മനുഷ്യരാശിയെ തന്നെ കാർന്നു തിന്നുന്ന ഒരു മഹാരോഗത്തിനെതിരെ നമ്മൾ ഓരോരുത്തരും എങ്ങനെയാണ് പ്രതികരിക്കേണ്ടതെന്നത് സംസാരിക്കാനാണ്. അക്കാഫ് 150-ലേറെ കോളേജുകളുടെ കൂട്ടായ്മയാണ്. പക്ഷേ നമ്മളിൽ പലരും മറന്നുപോകുന്ന ഒരുപാട് കാര്യങ്ങളുണ്ട്. ചെറിയ ചെറിയ കാര്യങ്ങൾ നമുക്ക് ചെയ്യാവുന്നത്, അത് നമുക്ക് ചെയ്യാൻ കഴിഞ്ഞിട്ടില്ല. അന്ന് നേരത്തെ പറഞ്ഞതുപോലെ നമ്മുടെ കൂട്ടത്തിലെ ഏറ്റവും എന്ന് തന്നെ പറയാവുന്ന പ്രധാനിയായ, ഏറ്റവും കൂടുതൽ ആവേശത്തോടുകൂടി മനുഷ്യരെ സഹായിക്കുന്ന കാര്യങ്ങളെ ചെയ്തിരുന്ന അഷ്റഫിനെ നമുക്ക് നഷ്ടപ്പെട്ടത് കഴിഞ്ഞ വർഷം ക്യാൻസറിനോടാണ്. ഇനി ഒരിക്കൽ കൂടി ഒരു അഷ്റഫ് ഉണ്ടാകാതിരിക്കാൻ നിങ്ങൾ ഓരോരുത്തരും ഇതിനെക്കുറിച്ച് കൃത്യമായ ബോധ്യം ഉണ്ടാവാൻ വേണ്ടി കൂടിയാണ് ഇന്ന് അക്കാഫ് ആസ്റ്ററിനോട് ചേർന്ന് ഈ ക്യാൻസർ വെബിനാർ നടത്തുന്നത്. നിങ്ങൾ ഓരോരുത്തരും ഇത് ശ്രദ്ധിച്ചു കേൾക്കണം. ഇതിനപ്പുറം നമുക്ക് ചെയ്യാവുന്ന, ഇനി നമ്മൾ ചെയ്യേണ്ട കാര്യങ്ങളെ കുറിച്ച് കൃത്യമായ ബോധ്യമുണ്ടാക്കി മുന്നോട്ട് പോകണം. നമുക്ക് മുന്നോട്ട് പോകാം.
For those who do not speak Malayalam, he is requesting each one of you to listen in very carefully as these distinguished doctors come and share their knowledge. Please do pass on this information to other people. You will be able to ask questions on the chat. Please do clarify all those questions as we take you through this session.
ആർക്കെങ്കിലും എന്തെങ്കിലും സംശയം ഉണ്ടെങ്കിൽ ശങ്കിച്ചു നിൽക്കരുത്. ദയവ് ചെയ്ത് ചാറ്റിലൂടെ നമ്മളോട് സംവദിക്കാം. ഡോക്ടേഴ്സ് അതിന് ഉത്തരം പറയുന്നതായിരിക്കും. നിങ്ങൾക്ക് അറിഞ്ഞുകൊണ്ട് തന്നെ മുന്നോട്ട് പോകണം, എങ്കിലേ വെബിനാറിന്റെ ഉദ്ദേശ്യം സഫലമാകും.
Thank you so much. We will now have a video about Aster volunteers.
Aster Volunteers has been started as a program to touch the lives of people. But we thought that we have to take it forward and it shouldn't be restricted to people inside the organization, and it has to be spread outside. I request you to contribute your time, your knowledge, and your resources for helping human beings who are our brothers and sisters. The best exercise for one's heart, it is said, is to bend and lift somebody who is in need. And that will give your heart the greatest strength. Let us all try together through the platform of Aster Volunteers to help people.
With that beautiful video, let us welcome Professor Dr. Jacob Alabat, who is the lead neurosurgeon at our Aster MIMS hospital in India. He's a senior consultant and head of neurosurgery. He started 35 years ago in this fantastic field of neurosurgery and has been pivotal in bringing subspecialty surgeries of stroke, epilepsy, and movement disorders at our Aster hospitals. He's also specialized in brachial plexal surgery, endoscopic neurosurgery, and does multiple other latest aneurysm surgery and endovascular clipping. His area of expertise is largely to do with endoscopic skull-based surgery and epilepsy surgeries, which also handle cancerous growths. With that, I would like to welcome Dr. Jacob to take over the session, please. Over to you, sir.
Good afternoon here and good evening or good afternoon in Dubai also, I suppose. We are holding a session for Aster volunteer workers on neuro-oncology and rest of the tumors, I understand. And let me speak a brief few words on brain tumors. That's what I'm supposed to speak on. Am I right?
I'd also like to introduce Dr. Shiv Prakash, who is here from Dubai side. Dr. Shiv Prakash Ratanaswamy is our consultant oncologist from Aster Hospital Kusais in Dubai, who would be on our panel interacting with you on this sessions.
Okay, thank you.
Good afternoon.
Good afternoon. See, time immemorial, if you see, brain tumors always had a dismal prognosis. That is in the hearts and minds of people. I always give a lot of importance to that for films. If you see old Hindi films or old Malayalam or regional films, most of the time the hero or heroine is diagnosed with a brain tumor and malignant brain tumor, glioblastoma, and he never makes it and he dies. This picture is ingrained in the hearts of many of laymen or ordinary people. To some extent, it is true. If you take brain tumors, the malignant brain tumors or the high-grade gliomas or metastasis do carry a bad prognosis. But benign tumors like meningioma, acoustic neuroma, schwannoma, all these carry excellent prognosis, just like any tumor in any part of the body. They are compatible with normal life, and once well operated in a good center and then followed up, he carries a normal life. So there is no difference now to me for brain tumors of the benign nature. But malignant brain tumors do carry a very bad prognosis. And often, from a layman's point of view, the first question often the relative or a patient asks me, why did I develop it? What is the reason why I developed a brain tumor? Very difficult to answer that question to you, to the layman or to the patient. But what little we know about is the reasons. If you look into the literature, why a patient developed brain tumor is benign tumors, causative factor is trauma. Meningioma is supposed to be a causative factor. Certain infections like Burkitt's lymphoma, Epstein-Barr virus has been some correlation. Then if you see in the literature again, you will see radiation, small or minimal radiation was a form of treatment for tinea capitis. And these patients on follow-up developed meningiomas and tumors in the field of radiation. So just like many other tumors in the human body, when radiation induces changes in the chromosomes or genetic, some form of change which is favoring a malignant potential, in such a person, often you get brain tumors. And this is often seen even when in our own practice. For example, a medulloblastoma boy, we operated at the age of 10 years or 5 years. This boy, when he grows up and lives up to 30 years or 35 years, he develops meningioma or other tumors in the supratentorial compartment or in brain's rest of the part. When a patient is radiated for a thyroid malignancy, all such people who had some form of radiation treatment for some other malignancy also is prone to develop a malignancy inside the brain. And often there is a correlation with many of the tumors, ovarian tumors, many female tumors, because we know meningiomas, for example, one of the most common benign tumors of the brain is often associated with receptors. And that is why in their treatment also receptors play a big role. So females have a more predisposition for certain benign tumors. And as we know, tumors definitely have a genetic predilection. And this genetic predilection, we know that just like our immunology, this surveillance of the body to prevent malignancy is weaker at extremes of age. When a child has more chance for malignancy, and old age also one has more chance for malignancy. And this is because the immunological surveillance system, the malignant surveillance system becomes weak, and the tumor suppressor genes takes activity over the rest of the body. Actually, we are all not developing malignancy because there is a very good surveillance system in the body which prevents developing malignancy. And that surveillance system becomes weak. You know, the p53 mutation and tumor suppressor genes, which are more in families, which are more common in certain individuals. We do not know why it is happening. So such reasons of genetic predisposition is there. Then we know certain tumors like neurofibromatosis, tuberous sclerosis, they are all more prone for tumor. Now we know the genetic mutation of these neurofibromatosis 1, 2, all these we know. So all these blabbing on tumors always does not go into the head of an ordinary layman. But we should know there is some knowledge in our part, in our medical science, on the knowledge of why somebody develops a cancer, brain tumor. It is not because of his fault. They often ask this, is it because of he did that, he had a trauma some time back? They will try to correlate with some incident in his life, during his birth or during his childhood. All these are not often correlating. Then the next question most often asked by people are, if I develop this, we are diagnosed with a brain tumor, and then they often ask this, how long this has been growing, sir? Was it a late detection? What stage of cancer it is? In brain tumors in general, we do not stage cancers. In brain tumor, most of the time, a high-grade malignant tumor, because the multiplication is in real progression of arithmetics. So a 1 centimeter size tumor grows into 3 centimeter, 4 centimeter within a matter of few days, because the tumor multiplication time is very high in malignant brain tumors. So he was all right, sir, till 1 week back, 2 weeks back. Suddenly he fainted, and suddenly he had a seizure. Suddenly he had a weakness. So how we could not detect it? So that questions are often asked by a patient. Was this tumor missed by us? Was this because the doctor who saw him before did not do the CT scan? So such questions are most of the time baseless. But a benign tumor can be picked up if somebody is going into, because it is very slow growing. Very important that this is being early picked up, because when a tumor is small, it is easily removed. And that is why regular eye checkups, regular audiograms, regular family history, and regular examinations, clinical examination, and if indicated, CT scans or MRI scan help us in early detection of brain tumors. But brain tumor scanning as a methodology in a population like India is not always not practical. But it is practical and it is feasible in a smaller, economically developed or richer nations where such screenings do happen on a basis, most of the time insurance based. So these tumors, when they happen, the third question they often ask, first question is, why, as I said, is this, why did I develop? Then how long it was growing? Is it treatable? Is it curable? The benign tumors, as I said in the beginning of the talk, that it is eminently curable. It is eminently resectable. It is eminently operable. And most of the time with adjuvant focused treatment, we can actually get cure many a time. He can have tumor-free intervals. He can have quality of life with good tumor survival rates. But malignant tumors, not often. Malignant brain tumors, we will have to buy time from God with lot of effort, with lot of treatment. But at the end, most of the time, in 90%, we lose the battle. We lose the battle miserably. And if somebody has a brain tumor patient in his family or in his life, he will never forget the last days or the difficult days, because that will always be there. And that will always be a trauma. And that is where our compassionate behavior, good attitudes, good supportive care, good palliative care will play a critical role in the care of such terminally ill brain tumor patients with diffused spread and where we cannot operate or where we cannot give them a good care. So when you think that the fourth question they asked, will I get a cure? You have to be very diplomatic. You should not put them into shock. I can share many stories. There are people who opt out of treatment when they read and understand the fate of a GBM, glioblastoma. But that is not for us to decide. That is always a treatment. But many a time, I have seen many people having false hopes and or given false hopes by people and people going into alternative treatments of medicine. Very painful to see, and they're going in for more trouble and ending up finally coming back, sir. And most of the time losing precious time. They're not operated by the neurosurgeon. They are not getting the right form of treatment. When we say all this truth, the facts about the disease, the relatives go all to alternative systems of medicine. So that is another problem we face when we face brain tumor patients. But in most of the time, if we see a brain tumor patient, we are able to counsel and make them understand that this is not what you should be doing. You should be professional and you should be scientific and follow the advice given. And if they do not come for follow-up, we try to call them, get them back and continue the adjuvant treatment. Because after surgery, when we say about radiation and chemotherapy, they take a jolt. So all these steps I shared as 5 points is whoever who is hearing it is to understand that this video on Aster volunteers on brain tumors, that you have to be realistic in the approach to brain tumors. To summarize, benign tumors in brain, just like any other tumors in the body, has got excellent prognosis. With good surgical acumen, good judgment treatment, they can have a near normal survival and tumor-free survival. But in malignant brain tumors, our prognosis are not very good. We have not still conquered the high-grade gliomas and GBM. World all over, a lot of research work and newer therapeutic regimes, immunotherapeutic regimes, and newer methodologies of treatment are being tried. But most of the time, it's all in failures. But people who are still hoping and working and doing research have to be acknowledged and applauded for the tumor, which has always cost lives of many, many people all over the world.
Should ask the panelists to go ahead. You were so simply put it together for the adult population is what I'm assuming. So does it work the same way when it comes to children? Would we see a better outcome in children with benign tumors and or versus malignant tumors?
Pediatric tumors, of all the pediatric tumors, if you see, the best pediatric tumor to be operated is pilocytic astrocytoma, true grade 1 WHO tumor. They are the ones, they are really, if you get a pilocytic astrocytoma, that's a tumor in the posterior fossa, a cystic tumor with a mural nodule, the classical cerebellar lesion, but not the lesions of the anterior visual pathway or hypothalamus. The posterior fossa pilocytic astrocytoma, if you excise it totally, and if you have no residual tumor, they lead a normal life. I have a lot of children who was operated 20 years, 24 years back and leading a normal life. They get married and they have children of their own. So because I have been working in the same place for the last 25 years, Calicut Medical College. And so I have I'm fortunate to see such kids. So pilocytic astrocytoma, excellent. But if you see rest of the tumors, for example, medulloblastoma. Medulloblastoma is the and ependymoma or the next midline posterior fossa most common tumors we see. They do not fare well. But there was always a mystery for me in medulloblastoma. If we take our surgical career, early we used to operate medulloblastoma and we used to wonder why some medulloblastomas do not fare well, why we have operated the same way, we excise the tumor. So we always used to wonder why, and we had a lot of criteria modified by. Now we know the genetic basis of why some medulloblastomas. Now the classification of medulloblastomas, as the panelists may know, is based on genetics. And often I have wondered why this medulloblastoma boy did well. They did a normal life. It is all predetermined by the great man above, God, that this medulloblastoma, this type of medulloblastoma is going to fare well, and some medulloblastomas do not fare well. Then there is another set of brain tumors actually in pediatric, which is very common. It's called the craniopharyngiomas, the supratendorial craniopharyngiomas, which come with affection on the visual apparatus, the endocrine system. They are also eminently benign, looks seemingly excisable, but very often they recur and they always take a toll on the development visual pathway and lot of difficulties for the parents in craniopharyngioma management. So craniopharyngiomas, although benign squamous cell origin, they also have not a very encouraging prognosis, but it is not a malignant tumor as such. Gliomas, just like in adult, will not fare well, but we often see other hematopoietic tumors, then other lesions, but benign lesions in pediatric also. But in pediatric, we should remember malignant tumors are more common than in adult. And pediatric tumors, if you see these PNETs and midline lesions, other than the medulloblastomas and ependymomas, they do not fare well. But always these pediatric brain tumors are a sensitive lot because parents are more concerned and more sensitive to whatever you do in these kids.
Thank you so much, Dr. Shivrakash.
Yeah. Thanks, sir. Nice to hear from you, and most of the things like you and me share actually. Oncology is same actually. Holds good for me also, same way. I'm happy to hear all your experiences and all your other pediatric population also you explained well. So nice to hear from you, sir.
The data on pediatric tumors are very scanty, actually.
Yeah. Because I can remember, like when I was in Chennai, one of my colleagues, batchmates, daughter, she's 8-year-old, in brainstem tumor. They cannot do biopsy also. They came for radiation. She recovered, but within 3 months, again she's gone.
So good that you provide that. This is again a very bad tumor in pediatric, intrinsic brainstem gliomas. We have nothing to offer. We are a failure. Fast neutron therapy and deep electron therapy is all. They say in US in few centers that it is being tried, but I don't think it is doing much good. It is not approachable and reachable for the average man. So intrinsic brainstem gliomas fare very badly. They are, when we see such a child, bright, brilliant, 6 years to 10 years in the first decade or second decade, coming with difficulty in walking, bilateral facial, bilateral sixth, bilateral diplopia, and it's all painful experience to see a brain tumor child with intrinsic brainstem glioma. Yes, sir.
Mr. Anu. Yeah.
സർ, ഞാൻ അനൂപ് അക്കാഫിൽ നിന്നാണ്. എനിക്ക് സാറിനോട് ചോദിക്കുന്നതിന് മുൻപ് ഇത് കണ്ടുകൊണ്ടിരിക്കുന്നവരോട് പറയാനുള്ളത്, നിങ്ങൾക്ക് ഏതെങ്കിലും തരത്തിലുള്ള സംശയങ്ങൾ ഉണ്ടെങ്കിൽ, if you have any questions on whatever doctor has explained, എന്നും ഇപ്പൊ ചോദിച്ചാൽ നമുക്ക് അത് ഡോക്ടറോട് ചോദിച്ച് മനസ്സിലാക്കാവുന്നതാണ്. ഡോക്ടർ അതോടൊപ്പം തന്നെ അവരാരെങ്കിലും ചോദിക്കുന്നതിന് മുൻപ് തന്നെ ഒരു കാര്യം അറിയാൻ ആഗ്രഹിക്കുകയാണ്. എവിടെയോ വായിച്ചതാണ്, ഏതാണ്ട് 29% ഓഫ് മാലിഗ്നൻസിയാണ് സാധാരണ ബ്രെയിൻ ട്യൂമറിൽ കണ്ടുവരുന്നതെന്ന് കണ്ടു. അക്കൂട്ടത്തിൽ തന്നെ 75% ആണ് സർവൈവൽ റേറ്റ് എന്നും കണ്ടു. എന്ന് വെച്ചാൽ ഏകദേശം മാലിഗ്നന്റ് ആകുന്ന ബ്രെയിൻ ട്യൂമറുകളുടെ സർവൈവൽ റേറ്റ് ഓൾമോസ്റ്റ് വെരി 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 ലെസ് ആണ് എന്നാണ് ഉദ്ദേശിക്കുന്നത്. ദിസ് ഇസ് ദ ഫസ്റ്റ് വൺ. ഐ ഓൾസോ ആസ്ക് ദ സെക്കൻഡ് വൺ. രണ്ടാമത്തെ ചോദ്യം എന്ന് എനിക്ക് മനസ്സിൽ തോന്നിയ ഒരു കാര്യം, നമ്മളെല്ലാവരും ഡോക്ടർ പറഞ്ഞതിൽ നിന്ന് എനിക്ക് മനസ്സിലായത്, മാലിഗ്നന്റ് ആണെങ്കിൽ ഒരു പരിധി വരെ നമുക്ക് ഒരു എന്താ പറയാ ഒരു കെയർ കൊടുക്കാമെന്നതിനപ്പുറത്ത് സർവൈവൽ റേറ്റ് കുറവാണ്. അങ്ങനെയാണെങ്കിൽ ഇതിന്റെ കോസസ്, സാധാരണ ലങ് ക്യാൻസർ ഒക്കെ ആണെങ്കിൽ സ്മോക്കിംഗ് ആണ്, അങ്ങനെ നമ്മുടെ കുറെ കാര്യങ്ങൾ പറയാറുണ്ട്. ബ്രെയിൻ ട്യൂമർ വരാതിരിക്കാൻ ഏതെങ്കിലും തരത്തിലുള്ള മുൻകരുതലുകൾ സാധ്യമാണോ? നമ്മൾക്ക് ഏതെങ്കിലും തരത്തിലുള്ള അഡ്ജസ്റ്റ്മെന്റ്സ് ഇൻ യുവർ ലൈഫ് സ്റ്റൈൽ ഓർ whatever, can you do anything of that sort to do, to ensure that we have a lesser possibility? I know, there is nothing called avoiding it, പക്ഷെ ഏതെങ്കിലും തരത്തിൽ ഇതിന്റെ സാധ്യത കുറയ്ക്കാനുള്ള അവസരമുണ്ടോ എന്നാണ് ഒരു പക്ഷേ ഇതിൽ കൂടുതലുള്ള സാധാരണക്കാർക്ക് വേണമെങ്കിൽ അറിയാൻ ആഗ്രഹിക്കുന്നത്.
Shall I answer in Malayalam or English?
Your choice, sir. It's fine.
I'll answer in English. Actually, both your questions are pertinent, and the facts that I did not cover in my talk. See, malignant brain tumors, the so-called gliomas, are divided into 4 grades. Grade 1, I briefly mentioned, pilocytic. That's a true grade 1 tumor, pilocytic. And the other end of the spectrum, or grade 4, is called glioblastoma multiforme. Grade 3 is called anaplastic. This is an old classification. The new 2021 classification I'm not quoting because that is more difficult for a layman to understand. And grade 2 is the next malignant tumor. So grade 1, 2, 3, and 4. Grade 1 is benign, excisable, compatible with normal life if totally excised. Are you with me? Okay. Grade 2 and 3, if well excised or near total excised and radiation and chemotherapy given, 5 to 10 years or even more than 10 years is compatible with life, with quality life, tumor-free survival, everything. But grade 4, true grade 4 GBMs, 90% do not make it more than 1 or 2 years, more than 1 or 2. But a less than 5 to 10% makes it for a longer lifespan, of which the tumor biology of these tumors are still being studied. We do not know why this less than 5% of grade 4 gliomas or GBMs, true, in the 2021 classification, there is true GBMs only grade 4. Nothing else is so they do not make it on a long-term basis. So does it answer my question on malignant lesions of the brain? These are all about primary tumors. Primary brain tumor. There is no tumor. But there are another set of tumors called metastasis. Tumors from the lungs, breast, ovary, and all metastasize into the brain. If it is a single mets, they have almost 1 to 2 years survival, depending on the primary malignancy's behavior. Breast in general has got good, kidney in general has got good, ovary in general has got good, but lungs in general not good. So that decides what decides in metastatic tumor, that is a tumor that has come from somewhere in the other part of the body into the brain, will not be the same depending on the it depends on the type of tumor and the number of metastases. If it is multiple metastases, if it is carcinomatous meningitis, it carries a very poor prognosis. To answer the second question yours, how can somebody help or advise to prevent brain tumors? Actually, there is a good lifestyle, a good, all these what we recommend for a long, healthy life can be recommended. But what is more important, if your first degree relative has got a brain tumor or developed a brain tumor, and you know that this is a close relative, first degree relative, you can go for tumor screening camps. You can go use, for example, your brother or sister had a brain tumor. You are a brother of that person who developed a high-grade glioma. There is no recommendations or protocols that you can go. But in such a situation, you can keep your alert, go for frequent checkups. If you feel so, and if the clinician feels so, you can ask for MRI scans. Genetic study per se is not recommended in a malignant tumor. But if your brother or sister had a neurofibroma, acoustic schwannoma, or a meningioma, you can go for a genetic study if there is a cluster or a family history which is very positive. Otherwise, as such, there is nothing to prevent brain tumors. That is why these tumors are most of the time regarded as spontaneous tumors. They are not a cluster of tumors or family proved or genetically proved tumors, except in syndromic situations, in certain family tumors and such situations.
Thank you, doctor.
Okay.
Thank you so much, sir, for your time and your patience in answering all our questions diligently. We have many questions, but because of the time, we will have to move to Aster Med City, Kochi. Dr. Kishore has joined us from there. Dr. Kishore is one of our top urologists with 15 years of experience in comprehensive management of complex genitourinary diseases. He's trained at some of the finest medical institutes in the United States and India, and he's an expert in robotic surgery, renal transplantation, urological oncology, advanced endourology, and laparoscopic urology. He has many firsts, some of which I will outline as being the first person to perform nose-assisted vaginal donor nephrectomy, which is basically a route in which we do a kidney transplant, robotic assisted radical nephrectomy, which is taking out a part of the kidney through robots, and IVC thrombectomy in India. He was also the third in the world to perform the transvaginal assisted robotic renal transplantation, the fourth in the world to complete 100 robotic renal transplantation surgeries, and the first in South India to perform robotic assisted renal transplantation. Dr. Kishore is one of the few surgeons in the world to perform a very rare renal sparing robotic prostatectomy, and which has minimal incontinence compared to conventional techniques. So today, I welcome Dr. Kishore to talk to us about prostate cancer, the silent killer. Over to you, Dr. Kishore.
Thank you. I believe you can hear me. You can hear me well?
Yes, we can.
Oh, perfect. So, first of all, at the outset, I thank the Aster volunteers and the Aster DM Healthcare and the partners for having me here to educate people regarding the prostate cancer. So without wasting much time, I'm going into the presentation. So why I call the prostate cancer a silent cancer? There are several reasons for that, because many of us, if you ask the layman, many of us don't know what the prostate is. There are misconceptions. People think that prostate is testicles, and many men who walk into the my clinic does not know where the prostate is. So just to educate you, these are the two kidneys here. And you can see a tube coming down. This is called ureter, and this is the bladder. And the prostate is right. The big arrow is the prostate. It is situated right beneath the bladder. So it's very deep organ. It's not commonly seen. So any disease, it may not manifest very easily. So if you see the difference, to highlight the difference between the prostate and the testicles are outside, and the prostate is very much inside the body, okay, and it is not seen. So this is how, if you have a magnified view, this is how the prostate looks like. This is the bladder, and this is the prostate here, and you have another tube coming out, which is the tube for the semen, where the semen comes into the urethra, to the urethral passage. So there are different types of prostate enlargement. Okay, this is the normal prostate. Okay, so you can see it is situated on both sides of the urethra. That is the passage of the urine, and this is the benign enlargement. If you see when a person say have a prostate problem, large majority of them are benign enlargement. That means non-cancerous enlargement. So what does this do? Non-cancerous enlargement. So this kind of compress the passage. So what happens is that you get symptoms. So when you have a non-cancerous symptoms, the patients will have some problem like passing urine. They might have go repeatedly to the bathroom like that. And this is the prostate cancer. So the prostate cancer actually it occurs on the outer aspect of the prostate. So it does not produce any symptoms. That is why I say it's a silent killer. Most often, if you don't do a proper diagnosis, the patients might reach in a very advanced stage, and we don't even know whether that was from prostate or not. So it doesn't produce symptoms in the early stage. So how do you detect it early? Okay. So for that, the first is you have to visit a urologist, okay? And the first step, as a urologist, we feel for the prostate by placing a finger in the ends. So every man who walk into our OPD get this examination, okay? And we see whether the prostate is hard or not to see that. And the most important test, the paramount importance is prostate-specific antigen. So it's a PSA test. It's very common, it's commonly called. Okay, it's only produced in prostate. So it's not seen in women. It's not like very seen in like young, I would say, children, even in males. But it's mostly seen in adult males when the prostate get developed and eventually elderly males. So the average value of the prostate specific antigen is 0 to 6. Something more than 6 rings the alarm bell. But there is a caveat for that. Sometimes mild enlargement of the prostate can cause some degree of PSA rise. If there is an infection of the prostate, you can get. Various, like a digital rectal examination, that means if you feel for the prostate, sometimes that can also cause a transient PSA rise. So it's not prostate cancer is not the sole cause, but there can be other causes which can elevate the PSA to a certain extent. So once the PSA is high, we do a test called an MRI scan, which is now the standard of care to see if there are any spots in the prostate. And this is a classical MRI scan of the prostate, and you can see the prostate here. So again, if you have a high index of suspicion, then we go ahead and do a biopsy of the prostate. Again, the biopsy is done in outpatient care, and we'll do a transrectal ultrasound guided biopsy. That means we are placing an ultrasound probe through this thing, and we locate the prostate cancer and we take biopsies from that. So that is how we do that. So once we diagnose prostate cancer, so what are the broad subtypes of prostate cancer? One is organ confined. That means it's limited to the prostate alone. The other one is you can spread all over the body or spread some parts of the body. It's called metastatic prostate cancer, which has definitely a bad prognosis. So the treatments that we do for the organ confined prostate cancer is, one is prostate removal, and that is robotic surgery, that comes in my purview. Then is a radiation therapy. That means you place radiation onto the prostate. And there is another upcoming modality called focal treatment of prostate cancer, where we use cryotherapy. That means ice technique, or you use like high intensity frequency ultrasound. You burn the tumors in the prostate. That is only done for tumors on a peculiar site of the prostate. While on the other hand, if you have metastatic prostate cancer, what we commonly do is a hormone treatment. Hormone treatment means the food for the prostate cancer, the fuel for the prostate cancer is from the male hormones. So what we do is that we give either some hormones, injections which antagonize the male hormones, or we just remove the testicles. That is for the metastatic prostate cancer. And most commonly, we don't use chemotherapy only in selected cases. We don't use very commonly in prostate cancer, especially in elderly. Like other malignancy, chemotherapy is a standard of treatment. Here, the people who receive chemotherapy is probably a minority. Most often, they just receive hormone treatment, especially elderly people. So this is the robotic surgery. I'm just playing a video of that. So what do you mean by robotic surgery is that generally we stand beside the patient and operate. In this instance, with the robot, I sit very comfortably in the corner of the room, and the robot will be docked on the patient here. And there will be an assistant who will be helping me to change the instruments. And I can get a three-dimensional vision through this console. This is called the console. And I control this robot with my both hands and with both the feet. And everything is controlled by the surgeon. So that means from that console, I can control the camera, I can control the instruments. And most importantly, this robot is a chip inside, which prevents any tremor. So if you are anxious or if you are doing it for the first time, still there won't be any tremor. And these movements are very fine and they're filtered. So we get the utmost accuracy. And this is like putting a tiny hands or tiny wrist inside the nooks and corners of the abdomen and then operating. So we can reach to any site, inaccessible site of the abdomen and then operate. This is used in other specialties like gynecology and gastrosurgery also, the same robot. So these are the tiny hands that I was mentioning. And this is the tremor-free surgery. And this is how it looks like in real life. This is a prostate removal. So I'm just fast forwarding that. So you can see I'm controlling the whole surgery with all the arms of the robot. And I'm burning, buzzing like that. So the robotic surgery offers numerous advantages compared to laparoscopic surgery, and it has improved our outcome, especially with the prostate surgery. And another question that commonly people ask, how can you prevent the prostate cancer? The best way is to early screening. Men over 50 ideally should do a PSA test every year. And you should, just like for any cancers, you should avoid smoking. You should take less red meat. People with familiar prostate cancer should be really vigilant, and they should have a screening at the age of 45 years. And just like any other cancers, a diet rich in fruits and vegetables, tomatoes, soybean, these are all helpful things. But I think the critical point is we have to screen the PSA every year. Thank you.
Thank you so much, Dr. Kishore. Those videos were very emphatic. I think we understood about how robots work. I'm sure that the panelists are very eager to talk to you. I can see Mr. Anu shaking his head. So should I let
Very
you
much,
go?
yeah.
Please.
Yeah, I
Over
think
to you.
because sir, എൻ്റെ പേര് അനൂപ്, ഞാൻ അക്കാഫിൽ നിന്നാണ്. ഒരു വളരെ പ്രധാനപ്പെട്ട ഒരു കാരണം കൂടിയുണ്ട് എനിക്ക് ഇതിന് ഇൻട്രസ്റ്റ് കൂടാൻ. There is a very specific reason because Akcaf is a group of, I'll say mostly 95% or 90% males out here. We have about 100,000 people behind us. I mean, but it is essentially and specifically, like you said, the last screenshots very clearly say men above 45 and 50. About ഈ പ്രായപരിധിയിൽ വരുന്ന വലിയൊരു കൂട്ടമാണ് ഞങ്ങളുടെ അസോസിയേഷൻ എന്ന് പറയുന്നത്. അപ്പോൾ we are really scared actually, and I have read somewhere 1 out of 8 men will be could be affected amongst even ourselves, which is very scary actually. And somewhere I also read 1 out of 41 could leave us. So we really need, നമുക്ക് കൃത്യമായിട്ട് അറിയേണ്ടത് എന്തൊക്കെയാണ് നമ്മൾക്ക് ഈ പ്രായത്തിൽ, കാരണം ഞങ്ങളുടെ കൂട്ടത്തിലെ ഓരോരുത്തരെയും ബാധിക്കുന്ന കാര്യമാണ്, കാഫിലെ എല്ലാവരെയും ബാധിക്കുന്ന കാര്യമാണ്. എന്താണ് നമ്മൾ ചെയ്യേണ്ടത്? നേരത്തെ സർ പറഞ്ഞത് കണ്ടു, there is PSA test and there is another way of straight away walking into your doctor and getting it checked. So we are very keen to know how all we could stop this, because I'm sure that many of us really need this test right away, tomorrow or the day after, if it is unless it is too late even. So over to you, sir.
Sure. I think നമ്മൾ ആദ്യമായിട്ട് ഏറ്റവും പ്രധാനമായിട്ട് നമ്മൾ PSA ടെസ്റ്റ് ചെയ്യാന്നുള്ളത്. നമ്മൾ എല്ലാ വർഷവും എല്ലാവരും ഒരു ബ്ലഡ് ടെസ്റ്റ് ചെയ്യുന്നതാണ്. അപ്പൊ അതിന്റെ കൂടെ പലപ്പോഴും ഈ PSA മാത്രം വിട്ടുപോകും. ഞാൻ ശ്രദ്ധിച്ചിട്ടുണ്ട് പലപ്പോഴും. അപ്പൊ അത് ഏറ്റവും പ്രധാനം. എല്ലാ പുരുഷന്മാരും ചെയ്യേണ്ട ഒരു ടെസ്റ്റ് തന്നെയാണ് PSA എന്ന് പറയുന്നത്. On the other hand, sometimes, unfortunately, the PSA can be still normal in presence of prostate cancer. So that is where the physician plays a big role. So if you visit a urologist, I think, just as we do a colonoscopy, say the US Cancer Prevention Task Force will advise colonoscopy every 5 years. So it might be a good idea to go ahead and visit a urologist. Many people that do it in US, but it is not very prevalent in India. In spite of not having problems, I think a visit to a urologist probably will be helpful, especially in people with a high risk of cancer, family history of cancer, and also high risk of prostate cancer in their fathers or brothers or first degree relatives. And just for any other cancer, prostate cancer is a better lifestyle. All the carcinogens are, implicated for prostate cancer. So definitely a lifestyle is quite important.
Dr.
Hi, sir. I'm Dr. Shiv Prakash on call.
Sure.
Nice to hear your lecture. And most of the time I have seen elderly, because of obstructive uropathy, going to physicians and taking treatment for BPH without assessment with the urologist. That's what I've seen, become late actually. Then going to metastasis, then will come. This is what we have seen in practice generally.
And it's also the second largest killer among in men's cancers, is what I'm hearing. Yeah.
Right. So I'm sure there are many questions which are coming up, and we can see them, but you've answered most of them. So I will move on to the next doctor today on the panel. And thank you so much, Dr. Kishore. You made it so crisp and informative. Thank you. Thanks for the videos as well. Moving on to welcome Dr. Geeta Karwal, who is our general surgeon from Medcare Sharjah. Dr. Geeta has completed her MS in general surgery and is an MRCS from Edinburgh, UK. She has done extensive work on minimal access surgeons, as well as she is a member of the Women's Association of Surgeons of India. She performs a wide variety of surgical procedures, which include breast surgeries or lumps, including breast cancer surgeries, cholecystectomy, appendectomy, and other surgeries. Today, she is here to talk to us about thyroid cancers. So over to you, Dr. Geeta. Thank you for joining us.
Good afternoon, everyone. I welcome you to this session on thyroid cancer. I want to thank the Aster volunteers for giving me an opportunity to share my knowledge on thyroid cancer in this very nice speakers are there in that they have given me a chance also. Thank you so much. And World Cancer Day was celebrated on 4th of Feb. I think this symposium or whatever we have arranged now is apt at this time because the World Cancer Day was just celebrated recently. That's why we have included many cancers topics. So today I'm going to give just a brief idea about what are thyroid cancers and how we can keep aware public about the thyroid cancers. So thyroid cancer, actually the September month is celebrated as the Thyroid Cancer Awareness Month. And we have a special ribbon for thyroid cancer, but not many people know about it. Even thyroid cancer awareness is very rarely done as a big program in majority of the hospitals or in many places. However, this World Thyroid Cancer Day is celebrated in September month. Whole month is celebrated as a thyroid cancer month, September month. October, I think all of you are aware that it's as, kept as a pink month or a breast cancer month. But very less people know about the thyroid cancer month. It is September and the ribbon has got 3 colors, the pink, blue and teal colored ribbon, as we have for all other cancers. And why the awareness is not so widespread is because the incidence of thyroid cancers are lower compared to the breast cancer and the prostate cancer, which is, and they also have a higher mortality compared to the thyroid cancer. And thyroid cancer is a disease with very good prognosis. The 5-year survival rate is almost 95%, means people, if 100 people are diagnosed with thyroid cancer, if they are treated with all the options, the surgery and the radioiodine, 95% of the people will be cured of the disease and 5-year survival rate is 95%. And this thyroid cancer, to come to the etiology of thyroid cancer, usually whereas it starts as a thyroid nodule, which is usually neglected by most of them, thinking that it's a small lump in the throat of the neck. So the thyroid, let me give you a brief introduction about the thyroid gland. It's a butterfly shaped gland. Let me share my screen for your better understanding. It's a butterfly shaped organ situated in the, let me go for, okay. Can you see the
We
presentation?
can see the screen, but would you be able to put it on the PowerPoint slideshow, please, at the bottom on the right hand?
Yeah, because it is Zoom is also open, not able to do it.
We can see it.
Yeah, I will just start this as a slideshow.
Sure.
Yeah. I'm not able to see this icon. Okay. Okay, let me just, can you see it now?
Please go. Yeah.
Yeah, I will go ahead. So
Please.
as I told you, this agenda I'll be speaking later. I'll just show a slide about the anatomy of the thyroid gland, where it is a butterfly shaped gland located in the front of the neck. And it is just below the Adam's apple, which is a prominent thyroid cartilage. And it weighs around 15 to 20 grams. And there are two lobes, the right and left lobes, which are situated on either side of the trachea. And there are two important nerves which are situated very close to the thyroid gland. So the surgery is really a critical surgery for thyroid. And because it is also surrounding the important structures like esophagus, which is a food pipe, and carotid artery and jugular vein. So any thyroid nodules can press upon these structures. So the patient who develops a thyroid swelling can develop dysphagia, that is difficulty in swallowing, or dyspnea, difficulty in breathing, and also sometimes they develop hoarseness of voice. So what now we understand the symptoms of thyroid nodules if we understand this slide, because it can compress. Any swelling coming up in the thyroid gland can compress on the food pipe, leading to difficulty in swallowing, and it can compress on the trachea, leading to difficulty in breathing, and it can compress on these nerves, the recurrent laryngeal nerves, which can give rise to the hoarseness of voice. So these are actually the symptoms of thyroid nodule as well as the thyroid cancer. So even in thyroid cancer, which usually starts as a nodule in front of the neck, can give rise to these symptoms, because these are called pressure symptoms or the compression symptoms. Because their gland is so close to these structures, these are the features which you can get in thyroid nodule, which can be cancerous or non-cancerous. So today's agenda of my topic is the importance of thyroid nodules and how do we evaluate the thyroid nodules with the investigation modalities like ultrasound scan, biopsy, which is done with a fine needle, like fine needle aspiration biopsy, and then how do we manage the benign thyroid nodules, non-cancerous thyroid nodules, and how do we go for staging and risk stratification, and what are the microcarcinomas, and what are the surgeries done for thyroid cancer. So what are thyroid nodules? Thyroid nodules are nothing but the excessive growth of the cells in the thyroid gland, and most of the time the cause is unknown, and most thyroid nodules do not produce the symptoms and they may go undetected. And what I usually tell my patients is, see, it is in front of the neck. So usually it is observed by the other person, the friend or a relative, who will tell that you have a swelling here because it is obviously seen. So coming to the epidemiology or the occurrence of thyroid nodules. So 50 to 70% of the adults have thyroid nodules, and most of them are in the age group of 30 to 40 years, and the incidence increases with age, and up to 60% of the women over the age of 60 years may have a thyroid nodule. And the incidence of thyroid nodules is more common in women. Even incidence of thyroid cancer is 3 times more common in women compared to men. So what is the question, what public should be aware of? Like, if I have a thyroid nodule, should I be concerned about the cancer? So the majority of thyroid nodules are benign, meaning they do not contain any cancer cells. They are simple benign thyroid nodule. So the malignancy rate is only 5 to 10%. So should I get it checked for all thyroid nodules with my biopsy or with a doctor examination? Yes, of course. Especially if you have a history of radiation therapy to the head and neck. Like sometimes in the olden days, not now, it's not practiced now, there were benign conditions like tonsil enlargement or enlargement of the thymus, for which the radiation therapy was given. And also the radiation, if the head and neck area has been exposed to the radiation therapy because of leukemia, lymphoma, or any other spinal cord tumors, we have to take care of our thyroid nodules. And there is also family history of multiple thyroid cancer or genetic syndromes like Men's syndromes, Cowden syndromes, where we have to take care of the thyroid nodules with the total investigations. So as I discussed with you, the symptoms are the dysphagia and difficulty in breathing while they are lying flat, and hoarseness of the voice, and there can be cough and rapidly growing lump. If these symptoms are seen by the patient, that means the patient has to take care and meet the doctor as early as possible. That means it can be a cancerous nodule. Hoarseness of the voice, the cough, and also too much pressure on the trachea, all this goes in favor of a cancerous nodule. So the first thing is consultation by a doctor, and the doctor will be ordering you the investigations accordingly. This is nothing but the ultrasound examination is an extension of the physical examination. So what do we, the first test we do is an ultrasound examination with a simple ultrasound probe, and this will tell us about the size and shape of the gland and also the composition of the nodules. See, composition of the nodule means the characteristic of the nodule. So some nodules are, irregular. Some nodules have some components, solid components, and that will indirectly tell us whether we need to go for biopsy or we can just monitor it by doing a scan every 18 months. And that will also tell us whether it is a suspicious of cancer or non-suspicious. And also there can be lymph nodes, where whenever the thyroid cancer has spread to the lymph nodes in the surrounding area, it can be seen in the ultrasound, which may not be which may not be seen by or felt by the physician. So these are the different characteristics of the ultrasound pictures, which show the different nodules. This is again showing solid components. This is a pure cystic component, which is seen here. This is just a slide to show you the different ultrasound pictures of different thyroid nodules. So this is when, do I need a biopsy? Yes, biopsy is needed whenever you have the irregular features in the ultrasound, which I discussed with you. If there is an extra capsular invasion, which they see in the ultrasound, means and there is a rapid growth, a history of a rapid growth of the nodule, or they see a suspicious lymph node in the neck, and the nodules which show a suspicious features, they all need to go for a biopsy. So the biopsy, no need for the public to get panicky about the biopsy, because it's a simple procedure which is done as an outpatient procedure, where the needle is inserted into the gland by the ultrasound guidance. We need an ultrasound guidance because we have so many vital structures in the neck. So the needle will be focused by the radiologist, and the radiologist will show us where the needle is going, whether it is going into the exact nodule which we need to take the biopsy from. And then these cells are examined under the microscope to look for the cancer cells. So let me tell a few words about benign thyroid nodules. Generally can be observed if the ultrasound is very suspicious, still your biopsy report comes as benign. Then also we need to repeat the biopsy at some point if the clinician is highly suspicious that the nodule may be malignant, but it's not giving total accuracy in biopsy. We need to observe it and repeat a biopsy. Then repeat an ultrasound in 18 to 24 months up to a total of 5 years, even if it is a benign thyroid nodule. If symptomatic or growing, you have to consider the intervention in the form of a surgical removal of the affected thyroid nodule. So coming to malignant thyroid nodules, 95 to 98% accuracy is there in biopsy when it is suspicious for malignancy. And also it depends on how the technique of biopsy and also the pathologist in your institution. And then after you diagnose with the biopsy, surgery. See, there are indications for surgery in a malignancy is different. Indication for surgery in benign nodules is different. A huge nodule, we call it as a colloid nodule because of accumulation of colloid, which is a substance secreted by the thyroid gland, which is compressing on the esophagus, that is the food pipe and the air pipe, the airway. We tell them to remove the nodule even if it is benign. But in surgery, for malignant nodules, it's a different protocol, which I'll be discussing in my next slides.
Dr. Geeta.
So indeterminate thyroid nodules, yes.
Dr. Geeta, just to be mindful of the time, please.
Okay, okay.
Because
just
we have our next speaker here as well.
Yeah.
And there are a lot of questions we would like to ask you.
Sure. So the indeterminate thyroid nodules where there are atypical features or follicular cells, which will most probably need a surgery. If the patient refuses surgery, we have to go for a molecular testing. So the molecular testing, again, as I discussed with you, only if they have a family history of thyroid cancer or those who are got a syndromes like Cowden syndrome or Men syndrome. And do all the thyroid nodules need to be surgically removed? This I already discussed. One is the concern for cancer. And if the benign nodules, very large nodules with compression symptoms, and substernal nodules which are going down into the chest. The surgeries which are done for thyroid cancer are total thyroidectomy and partial thyroidectomy or only the lobectomy where we remove the involved gland. And after it is proved as cancer, depending on the stage of the cancer, if the thyroid cancer is in advanced stage, if it has spread beyond the thyroid gland to the lymph nodes, then we advise them about radioiodine therapy, which is again a special radiotherapy given for thyroid cancer. And then, yeah, there is staging. The staging is done according to the pathologist, the cells and the extrathyroidal extension and age also. Stage 1, age less than 55 years, and they have a good prognosis, whereas advanced stage, they are not having that good prognosis. So surveillance is nothing but the follow-up which we do for thyroid cancers, which has to be done, especially in those patients who try to postpone the surgery. We need to do a proper follow-up. There are 3 types of thyroid cancer: papillary, medullary, anaplastic, that is differentiate thyroid cancer, where we have papillary and medullary cancer. And also the anaplastic is the most serious type, which will need a this one, which has got a least survival rate compared to the other cancers. So let me tell you about the take-home message. Thyroid nodules are very common. The majority are benign. Thyroid cancer is very treatable and most patients are survivors. This is a very important take-home message. So once you're diagnosed with thyroid cancer, no need to get panicky. It has got a very good survival rate. And most surgery is now minimal access surgery, where earlier we used to make a big cut from one end to the other part of the neck, which is not done now. We do it with a small cut, and also we do a endoscopic surgery, where the approach is from the armpits or from the breast area. We do a minimally invasive surgery for even for thyroid cancers. So benign thyroid nodules, microcancers, there are again alternatives to surgery in the form of radiofrequency ablation, where surgery is not needed. Thank you.
Yes, thank you so much, Doctor. Dr. Shiv Prakash.
Yeah, Dr. Geeta, actually, one of the things we have seen as a surprise is like in UAE 2020 census, thyroid cancer has become the number two
Yes.
cancer after breast cancer in the thing. So it was nowhere in 2000s, and it came within 10 in 2010, but now it is number 2 actually. 12% of women are diagnosed with cancers or with thyroid cancer. Thanks to the technology, and ultrasound is easily available. That may be the commonest reason, maybe. Rather than in India. India still cervix is second commonest, and thyroid has come up as 4th or 5th level. But here it is second most common after breast cancer. That's
in the whole world, I think it stands at the 12th position.
Yeah, 12th position. It was nowhere inside the thing, but in UAE it is second.
In UAE, yes.
Second most.
And I've also observed the thyroid cancers in people from Kerala. This, I don't know, maybe the population distribution.
This has been proven because of the cosmic radiation in the area, because Kerala is having the rural registry for the cancer registry we have. So from there only they have registered more. Then the research have found out like they have cosmic radiation. That is the reason that border and Kerala are having more.
Yes. And
that may be the reason for UAE also.
Yes.
Being more common population.
Okay. Thank you, Doctor.
Thank you, Dr. Shiv Prakash. Ms. Anu would like to ask Dr. Geeta a few questions.
Dr. Geeta, Anu here from All Kerala Colleges Alumni Forum. What you said is quite scary. We're all from Kerala.
And in the UAE.
And in the UAE. And I'm talking on behalf of women right now. You did mention that women have a higher rate or are at a higher risk of getting thyroid cancer.
Yes.
Is it linked to their reproductive cycles? Is there an age? Is it linked to menopause, or is it at a younger age that they're more susceptible?
Yes.
And is there something that we can do to prevent?
Yes. This the risk in women for thyroid cancer has been not completely proven. Has been told that it's same like breast cancer risk. Estrogen, progesterone, the same reproductive hormones are responsible for an increased incidence of thyroid cancer. Actually, it's not related to iodide deficiency. It is seen in high iodide intake areas, especially the follicular variety of thyroid cancer. So it's mainly the hormones, but it's not completely proved like breast cancer. There has been a theory that this is the reason for the women to, develop thyroid cancers more. And prevention, of course, the prevention is a very good question you asked me. The earlier evaluation of the thyroid nodule. The earlier we evaluated, it is like prevention, because the minute we remove the nodule, there is no spread. It is like it behaves like a benign disease. The faster we remove the nodule.
I think it goes for every cancer. Early detection.
Yes.
True. Always saves life. Thank you so much, Dr. Geeta.
Thank you so much, Dr. Geeta, for your time and answering our questions. We will now move on to Dr. Keshwan. We welcome Dr. Keshwan, who is a consultant pediatric hemato-oncology in our Aster Hospitals, Kerala. He completed his MD Pediatrics from Madurai Medical College and fellowship in pediatric hemato-oncology and bone marrow transplant from Apollo Cancer Hospital. He's trained in treating children with blood disorders, childhood cancers, and has experience with over 250 pediatric bone marrow transplants. He's also partaken in various national and international conferences. His area of expertise being hemato-oncology, which is very rare in childhoods as well, to find a specialist. So over to you, Dr. Keshwan, who will be talking to us about childhood cancer.
Thank you, ma'am. Thank you. So we had recently celebrated our World Cancer Day. And childhood cancer, when we say cancer in children, it is very, very rare. only about 5% of the total malignancies comes in children. Suppose you have 100 cancers, of which only 5 will be children. So it is very, very rare, and most of the childhood cancers are highly curable. So that is one thing we need to know. But when you go into a background information about pediatric cancers in our country, though we know that it accounts only for about 5% of childhood cancers, every year, easily 45,000 to 50,000 children are diagnosed with cancer. But how many of them are getting the proper treatment? So that is also most important thing. Main thing is, whenever a child is detected with cancer, the family has the social stigma, fear of pain, a fear of death, whether the treatment would harm the child. So many parents don't even, go and get the treatment. Once they get the diagnosis of cancer, it is still common in our country. So most important thing is, the most important aspect in this talk is to highlight about the childhood cancer and it's how curable it is. It's a highly curable cancer. And we need to know that it is one of the leading causes of death in children, though it is very rare. And what is the cause of a cancer in a child? There is no specific cause per se. Childhood cancer doesn't have any cause. Some people think whether it is because of their sins, any changes in their food habits, or because of the food, because of their environment. This I'm talking only about childhood cancer. Whether does environment play a role, whether food habit play a role? At present, there is no specific evidence towards that. And many people also have the stigma, like cancer spreads from person to person, which is not there. So that is first point. Second thing is cancer hereditary? Is it genetic? So more than 99% of childhood malignancies, it doesn't have any genetic predisposition. And the main question is, my first child is having cancer. Will my second child develop cancer? The answer is no. Only very rare pediatric cancers, like some tumors in the eye, we call as retinoblastoma. There we can have a genetic predisposition can be there. So many doctors would say we have to do genetic test in the bone marrow samples of childhood cancer. It is basically the genetic mutation which happens only in the cancer cell and not in the other cell lines of the body. So that is very important to understand. So one sibling is affected with cancer. Is there an increased risk for another childhood cancer? The answer is no. That is most important thing that we need to know. Like we know that, so these are the basic things. And any medications taken by the mother during the pregnancy, will it affect the fetus causing cancer? Unwanted medicines. So nothing much proven relation has not been there. So how do you diagnose cancer? Is there any signs and symptoms of childhood cancer? Will be the next question. So when we say that there is no specific signs and symptoms, it can be non-specific. It can just be a simple fever. A cancer in child, can just mimic any other normal conditions. Childhood and acute lymphoblastic leukemia, for example, the commonest childhood cancer, can just mimic like any other viral fever. Child will have only fever for 2-3 days. Some children have been diagnosed with blood cancer when they do a routine CBC examination for doing a circumcision. So, and some childhood cancers are very insidious in onset, very slow growing, and they also mimic non-cancerous condition. So there is no a specific thing like this symptom points towards this cancer. And when you look at a pediatrician who is practicing in a peripheral hospital, after when a pediatrician is practicing in a peripheral hospital, he may only see maximum 3 to 4 childhood cancers in his lifetime during his practice in a peripheral hospital. Most important thing that we need to know is cancer has to be detected early. So if they are detected early, the cure rate is very high. And second thing is, suppose some of the solid tumors have staging. If they have an early stage, the intensity of treatment, will be less amount of treatment might be given, so that the side effects of this chemotherapy can also be minimized. The late side effects, like a child is diagnosed with cancer at the age of 5 years, he undergoes treatment for 2 to 3 years, but he will be living up to 60 years. So once he is completely cured of cancer, the late effects, the side effects of the high dose chemotherapy, if it is minimized, if the cancer is detected at an early age, then the late side effects can also be minimized. That is the most important thing. So what are all the warning signs of childhood cancer? As I've already mentioned, childhood cancer mimics non-cancerous condition. As I said, the commonest cancer in children is blood cancer. How does it present? The child will look just, pale when the hemoglobin is dropping. The child looks very pale. He will look white. There may be small bleeding spots on the hands. We call petechiae. Some children will have bone pain. Some children will have joint swelling. or the continuous fever some children can have. Sometimes if a tumor is present in the, the chest, you can have just cough or breathing difficulty. Sometimes childhood cancers are detected incidentally. Suppose when a child is going to a pediatrician for the routine vaccine visit, when they touch the abdomen, when they do an abdominal examination, when they touch the tummy, they may find a mass. They will do an ultrasound. So that will, point towards a cancer. So basically, childhood cancer can mimic multiple non-cancerous condition also. And all the pediatricians should have a very high index of suspicion whenever encountering any child with any complaints, though it is very, very rare. Second thing is childhood cancer, which is the commonest type of childhood cancer, as I already mentioned, is blood cancer. We say acute lymphoblastic leukemia, acute myeloid leukemia. These are the two blood cancers. So blood cancer is the commonest cancer in children, among children. Second thing is, among the blood cancer, acute lymphoblastic leukemia is the commonest cancer, which is highly curable. The cure rate in this blood cancer is more than 85%. Suppose you treat 100 children with ALL, acute lymphoblastic leukemia, at the end of 5 years, more than 85% of the children will be alive. Main thing is only a very few fraction of children, the disease can come back. This is the commonest cancer I'm talking about. Second group is the brain tumors. So first is a blood cancer. Second most common cancer is a brain tumor. Brain tumor, of course, is not one specific cancer. It's a heterogeneous group. You have the gliomas, you have medulloblastomas, a lot of types are there. So second most common is a brain cancer. And the third type of cancer is the lymphomas. This is the third most common, lymphomas. We have lymph nodes all over the body. So whenever there is swelling in the lymph nodes, so that is the third most common malignancy. Other solid tumors are also there, which will include the tumors in the abdomen. Like if you have a tumor arising from the kidney, we say it's Wilms tumor. We have neuroblastoma. Among the abdomen tumors, neuroblastoma is more common. And we have rare tumors like tumors in the eye, which is retinoblastoma, soft tissue tumors, we say rhabdomyosarcoma, bone tumors, especially bone tumors occurs during the pubertal spurt, during the adolescent age group, which includes osteosarcoma and Ewing sarcoma. So these are some of the common childhood cancers. Is it a cancer? How do we diagnose? So each cancer, suppose a blood cancer, it will be diagnosed by a blood test, confirmed by a bone marrow examination, because the blood arises from the bone marrow. So that is a blood cancer. So if it is a solid tumor, we will need to do a tissue diagnosis will be needed, maybe a biopsy of the tumor, also a imaging, a local imaging. For example, if it is an abdominal tumor, suppose initially they would have been seen in a peripheral center, they would have done a CT and they would have come here and we do a biopsy, which says it is neuroblastoma. If it is a solid tumor, we have to stage the tumor. So whether it is present only there or is it present all over the body. So we do something called PET scan for staging. Some of the tumors will need PET scan for staging purpose. And all the tumors, there is no hurry except in some emergencies. There are some times where there will be an oncological emergency where we need to start treatment very fast. And because of that, only in those conditions, immediately after taking a biopsy, we start the treatment. For other cancers, we can wait till we get the complete report and then we stage the tumor and then we proceed with the treatment. So for example, if we talk about the commonest commonest cancer in childhood, which is acute lymphoblastic leukemia, your complete blood count, you will have a peripheral smear. We do a bone marrow examination. From the bone marrow, we take many tubes, heparin tubes and EDTA tubes, and special stains would be done there to identify what type of cancer it is through flow cytometry and other markers to look at the type of the cancer, and we risk stratify. So this is most important thing. How do we treat the childhood cancer? So any cancer treatment is multimodal in its approach. It's generally we say 3 arms. You have a chemotherapy arm, you have a radiotherapy, and you have a surgery. Suppose it is a blood cancer, majority will need only chemotherapy alone. If it is a solid tumor, for example, it is a neuroblastoma. Neuroblastoma will require chemotherapy to reduce the tumor size, do surgical excision, followed by chemotherapy. Suppose if it is high-risk neuroblastoma, you may even need to do a bone marrow transplant followed by a radiation therapy. Like some solid tumors, like bone tumors, which occurs in the bone, like osteosarcoma, we give chemotherapy to shrink the tumor cells, do surgical excision, again followed by a chemotherapy. So it's a multidisciplinary and a multimodal form of treatment. And what is the duration of treatment? That will be the question. So each cancer has a different, different duration, varies between each cancer. The commonest childhood cancer like acute lymphoblastic leukemia, the treatment will go between 2.5 to 3 years, where initial 4 to 5 months, they will need intense chemo followed by tablets. Some tumors like acute myeloid leukemia will require intense chemo for 4 months. Some tumors will require for 1 year. It varies depending upon each of the chemo. The next question is childhood cancer curable? Whenever a cancer, a word is heard, the entire family gets shattered. So they will be they'll be shattered. They will think cancer is equal to death, but that is not so. Cancer should be taken as any other disease, and they need to understand that majority of the childhood tumors are highly curable. That is the most important message which I want to emphasize in this platform, so that all the childhood cancers are highly curable. The commonest cancer, acute lymphoblastic leukemia, we say is more than 85% cure rate. When you take lymphoma, the cure rate is more than 90-95% in children. It's very highly curable. Overall, some cancers will have very poor prognosis, but generally the common cancers have a favorable prognosis, luckily. So in India, in a country like India, in a developing country, we say out of 3 children, 2 children will be completely cured of cancer, living a normal, healthy life. This is in a developing country, 2 out of 3 children can be completely cured with cancer. And most important thing is, especially in a solid tumors and all, early detection, early diagnosis will help in improving the survival. If it is a localized cancer, we say the prognosis is better than a metastatic when it is spread all over the body, where the survival will be very poor. And some cancers will again relapse. That is the first question which parents ask. Some cancers, even if they relapse, overall, relapsed cancers have a poor prognosis, but there are some cancers, even after they relapse, they survive well. Now, because of the advancement in treatment, for example, you have an acute lymphoblastic leukemia. Even if they relapse, the chance of curing them post-relapse may not be 85%. But if all facilities are available, like high-dose chemotherapy, risk stratify, give them immunotherapy, bone marrow transplant, the survival is close to 50%, more than 50%. And the biology in childhood cancer is completely different from an adult cancer. For example, acute lymphoblastic leukemia is seen in children as well as in adults. But the Ph positive ALL, some high risk types are seen only in 2 to 3% of childhood leukemia, whereas it is seen in 25% in adult cancers. So most important thing is early detection of childhood cancer is very important. Routine screening is not needed because majority of the childhood cancers, it is not preventable. And since there is no environmental factors or any other association associated with it, only like a few, like a predisposition syndrome, like retinoblastomas and a few cancers may need a screening, especially if an elder child has a bilateral retinoblastoma. And the younger child, we need to screen them. And whenever the child after delivery, child will be in the contact with the pediatrician during the routine follow-ups, during their vaccination and immunization schedule, where they will look at the eyes and do ultrasound, not ultrasound, sorry, abdominal examination to look for any mass. Some cancers can be picked up like that. So it is highly curable. Childhood cancer is highly curable, and yeah, they will have a normal life. Many children, the main the highlight is a child diagnosed as an ALL at the age of 2 years. At the age of 10 years, he would have never known he has had a cancer. So they will never have that. They will forget whatever they had during their early lives, and they will have a normal lifespan, normal employment. Many of them will have they get married, have children on their own, and fertility, everything will be preserved in majority of the cancers. Of course, some high dose cancers where you need to give high dose chemo and all, maybe the fertility may get affected. But in general, they survive well. More than 2/3 survive into adulthood, into a long life. Most important thing is the gap, the lack of awareness, where to get treated, how to get treated, and the financial restraint. The financial many patients have financial restrictions which impede them in getting the treatment. But I think there are many non-governmental organizations, governmental organizations which plays an important role in helping in delivering out these processes. And I think even MIMS Calicut recently we have associated with the Hope Foundation, where they will be helping all acute lymphoblastic leukemia cancer children treatment. They will be helping in monetary support, and they also will help in providing homes for these children where they will be able to stay nearby so that the both home and food will be given to the child and the family for those 5-6 months initial intense treatment. Not just leukemia, any blood cancer, they provide the home. So like this, many organizations are there, like Can Kids, another organization which is present all over the country. So there are multiple organizations where childhood cancer treatment is, they ensure that the children get the required treatment. Yeah, thank you.
Thank you so much, Dr. Keshwan, for taking us through that. It's so reassuring to hear that, children survive this. And I like the part where you said that they forget about it and they move on with their lives. I think that's the beauty of being children, where they can grow out of things. And Doctor, you have a question?
Actually, I think we are never met, but we are, I think, closely associated. Like I am from Madurai Medical College. My MBBS was from Madurai Medical College. And I was with Apollo also, with Revati Rajan, I was closely associated when I was in Chennai.
Oh, okay.
I was Apollo specialty only I was working before coming
Okay.
to
Ms. Anu has a question. So
Yes, Dr. Keshwan, Anu here from All Kerala Colleges Alumni Forum. You did mention that many of the symptoms of cancer in kids might be simple as a fever.
Yeah.
So when our kids fall sick, nobody would want to think, now we will start thinking, oh, he's got a fever. What is it? What is it? So this fear comes in. But how do we monitor? How do we ensure that it is not something worse than a fever?
Okay. So commonest cause of fever in any child is just a simple viral infection. So when I was doing my super specialty training, I had my child was 1 year old. So any fever, automatically my thought process goes towards the, is it a cancer? So that naturally happens. But I think childhood cancer is very rare, very, very, very rare. And any pediatrician will see only 2 or 3 in their lifetime, whenever they in a peripheral hospital, not like a hospital like NIMS and all, where referrals will come, suspecting malignancy, they refer. A pediatrician in his periphery will see it very rare. Commonest, as I told, childhood cancer is blood cancer. Generally, if your fever lasts more than 3 days, more than 72 hours, pediatricians will do the basic workups like a complete blood count, a urine routine, and all those things. That can actually pick up, simple, like the commonest cancer can be picked out like that. Less than 72 hours of fever without any focus, generally it will be an URI, running nose and all those things. So it always requires a high index of suspicion, of course, but it is very rare, but not to worry much is what I feel. So generally for less than 3 days fever, nothing much. More than 72 hours, basic tests will be there, where maybe it can be picked up, if at all it is, which will be very rare.
Thank you. Thank you so much, Dr. Keshwan.
Thank you.
thank you so much, Doctor, for your time and telling us about a very critical thing. As parents, all of us worry about our children. And I think you very beautifully gave us a simple and as to what we should do and how we should look at it. Thank you so much.
Thank you.
Now, we've had Dr. Shiv Prakash with us all through, and I would like to go into his introduction before he starts his talk on breast cancer. Dr. Shiv Prakash Ratanaswamy is from our Aster Hospital, Alcosais. He's our consultant oncologist. He did his MBBS from Madurai Medical College, MS from PGIMR Chandigarh, MCH from Lucknow in surgical oncology, FACS in gynae oncology from the Fellow of American College of Surgeons, the FEBS, and he's presented various papers in national and international conferences. He's got about 14 years of experience in the field of surgical oncology. He worked as a consultant surgical oncologist in Zuleika Hospital, Dubai and Sharjah since 2017. He's worked in Apollo Specialty Center before he came to Sharjah. And he's now with us and he will take us through his talk on breast cancer. Over to you, Doctor.
Yeah, welcome everyone. Thanks for an informative evening today from Aster Hospitals. I will be talking about breast cancer, its awareness and the treatment. So everybody knows like breast cancer is the commonest cancer in the world, even compared to men and women. So it is the commonest. So first is the breast cancer comes, and even worldwide in India also and in UAE also. And just I'll start with the reasons why it comes, breast cancer comes actually. So first and foremost reason is the hormonal action. So hormonal action means any person who gets periods like menarche, the first periods coming very early and menopause coming very late. It means you are in a higher time of reproductive age. If you are like getting menarche at 10 years and menopause at 50 years, it means like 40 years you are under constant hormonal action on your breast. And the protective mechanism comes with pregnancy, that is amenorrhea. If you don't have periods, you get protection. So more the number of pregnancies and earlier the pregnancy is one of the helpful things. We cannot force people for getting more pregnancy or no to get early marriage, but this is a protective factor. If you ask how to protect from hormones, early first childbirth will prevent you because when the puberty starts, your breast development starts. So when it starts, actually, it attains a maturity. No, that is a maturity level when there is a growth. That maturity level comes at lactation, pregnancy and lactation. So if you don't give that maturity till 30 years of reproductive age or never had a like nulliparous, no, never had a pregnancy and all, that will give you a very much hard effect on your breast with the hormonal actions. There will be erratic hormonal action. Sometimes what happens, the cells change the behavior and it becomes cancer. So that is the very commonest reason where we can have like nulliparous women. We are seeing working women with urban culture. That is why it's called initially westernization increases the cancer risk. So one of the westernization is late marriages and not having much of childbirth because the culture changed from early marriage, multiple kids to late marriage and 1 or 2 kids. So this is the westernization which we were talking about before also. That is one of the commonest reasons for breast cancer. The other reasons include obesity, one of the things, postmenopausal obesity. After menopause, if you're having obesity, even though your hormones are stopped, the excess steroids will go into estradiol, hormone production. That will also give you a risk for breast cancer. So obesity is another risk factor. Then as usual, alcohol and smoking will always consider as one of the carcinogens which causes breast cancer. And genetic reasons, 5-10% are genetic. Actually, you don't have to worry about 90% are not genetic. So only if you have a very high suspicious, and that also 45 years, less than 45 years. If you are close family relative having a cancer less than 45 years and they had a very advanced cancer, they died of the disease, then the chances of genetic predisposition is more for you. How we call as a genetic predisposition? First degree means your own father, mother, or your siblings. They come in first degree. Second degree means your uncle, aunt. Third degree will be your uncle, aunt's son and daughter, cousins. So the first degree has the more risk. Second degree, some risk, and third degree, rare risk actually. So you don't have to confuse and don't have to worry much actually. And these are the commonest risk factors you can tell for breast cancer. The second is like what are symptoms actually. So if I tell symptoms, then everybody will feel like that, same like children having the fever and all. So any breast lump which is growing in size, or any skin changes, sudden skin changes like redness or ulceration in your skin, or your nipple going inside, or there is a discharge from the nipple, which is red or pink in color. So these are the reasons which are the commonest symptoms of breast cancer. But 80% of the lumps which are seen in the breast are benign, not cancerous. Only 20% are cancerous. So that's why like you don't have to worry about every symptoms. Just to go and meet a surgeon or a physician, then they will clear the doubts. Then once a lump is there, then next how to diagnose actually. When people come with a lump to us, we start first with triple assessment. Triple assessment means first is we will see first, clinicians will assess. Second is imaging. Imaging can be ultrasound or a mammogram depending on the age. Less than 40 years, we prefer ultrasound because the breast density will be very high. We cannot see in mammogram. Mammogram is like an X-ray. Everything looks white. So we want something in the black background. We want something in white. So for that, actually, what we do is like we do ultrasound for less than 40 years and mammogram for more than 40 years. So this is our first diagnostic test. After imaging only, we go for biopsy. The biopsy is most common we take is a core needle biopsy, thicker biopsy, not like a fine needle, little thicker biopsy, so that we can get tissues and we can get confirmation. So when these three things are done, we call triple assessment, we'll come to know what it is. 100% proof mostly from biopsy we'll get whether it is benign or a malignant lesion. If it is benign, then we'll give an option. It can be Low risk, intermediate risk, or high risk benign features. If it is low risk, we tell them to follow. Intermediate risk, we tell them to remove it actually, and beyond regular follow-up. If it is high risk, always we remove it, and we have some risk reduction strategies like tablets are there, and like hormone tablets. We give it for 1 year actually. So these are the treatment for benign lesions. What if it is cancer? If it is cancer, then we know it is cancer, it has been proven. Next step we do is same biopsy, we check whether that type of cancer is hormone dependent or non-hormone dependent. And if it is having any bad markers like molecular targets, HER2 we call. So all these things will be tested in the same sample which was taken for the biopsy. That will decide your treatment option, your chemotherapy, everything is decided on that biopsy sample only. And second is staging. Staging means we know it is cancer. We have proven what type of cancer it is, how aggressive it is, like grade 1, 2, 3. We have like how aggressive, slow growing, intermediate growing, or fast growing. All we will get in the biopsy specimen. But what about the stage, whether it has spread to other places or not? For that, we will do a, like if it is stage 1 or stage 2, we will do only X-ray and ultrasound. X-ray of the chest, ultrasound of your abdomen to check your liver status, your ovary status, and also your lungs. If it is stage 3, we will do CT scan of your chest, of your abdomen, and also bone scan. Because the chances of getting in bone also is more when it goes to stage 3, like it is locally advanced disease. If it is stage 4, or like very patient comes with a very large mass in the breast and big lymph nodes in the axilla, we know it is locally advanced, we go for a PET CT scan, that is whole body CT scan, so that we can identify your tumor. The tumor, where all it can spread is like most common, it goes to bones. Second is your liver, then your lungs, and then your brain, and rarely to the ovary and adrenal glands, which is above the kidney. So these are the commonest places where you get a spread from breast cancer. That's why we do a PET CT scan from head to foot, like from head to middle thigh, we will do, and we will identify any spread is there or not. Most of the time, we are not getting any spread cancers. Most of the time, we are stage 2, stage 3. As far as Asians are concerned, it is mostly stage 2, stage 3. Stage 1 is mainly from the screening. When people are very aware of, educated, and aware of breast cancer, they are doing regular screening, they come in stage 1. Like less than 2 centimeter, we consider stage 1 actually. In that also, we have 1A, T1 like A, B, and C. But still, they come very early without any spread to the lymph nodes. And we have all the options available like breast conservation surgeries and no chemotherapy. All this possible when they come at stage 1. And next, I will go to the stages we have discussed. We discussed about the types of tumor. Next will be the treatment options. Treatment options will be surgery, chemotherapy, radiotherapy, and hormone therapy. Surgery, we have 2 types of surgery, mainly the surgery for breast and surgery for your axilla, the side parts. Surgery for breast can be 2 ways: conservation of breast, removal of the breast. Now we are 70% we are going for the conservation because we are identifying it earlier. Second is axilla part. Axilla part also, before we were removing all the lymph nodes. Now we are not removing all the lymph nodes. If the lymph nodes are negative by in investigations already by ultrasound and by PET CT scan, then we go only by we call sentinel node biopsy. We give a dye injection near your nipple areola during operation. We identify the colored lymph nodes, the first station lymph nodes. We check them on operation time itself. We call frozen section. If they are negative, we don't touch the axilla. It will prevent your arm edema, your drainage for a long time, 1 month, having drainage tube. All will be done, and we are sending the patient same day or the next day actually. All the breast cancer surgeries are sending same day. If there's only breast conservation and no axilla, if you can remove the breast or your axilla, then we are sending next day. So we are not keeping the patients more than. After this, actually, we have option of plastic surgery. We don't call it as plastic, we call it oncoplastic because we are doing it on the same time, immediate reconstruction. We are not reconstructing later. So we call it as an oncoplastic surgery where wherever even breast conservation, the volume is more than 20%, 30% lost, we can pull it up with nearby tissues or same tissues. If we are removing the breast also, we have the option of implant and option of other tissues from the abdomen or from the back to put it on your breast area to cover it. So these are the options we are doing nowadays, and it is very commonly done actually. And then the chemotherapy option comes only if you are hormone negative or a very high late stage of tumor, then the chemotherapy option definitely comes into picture. If you are in a very early stage, hormone positive, we have chances of avoiding chemotherapy. Chemotherapy will be for 8 sessions. That will be like your medical oncologist will explain you once you get the diagnosis done and surgery done. And sometimes we give chemotherapy first, either to it is local advanced, so to treat the tumor, or if it is already advanced, we want the micrometastasis. We call some cells may be missed and gone into bloodstream. We want them to be controlled before you go in for surgery. Because surgery, if you do first, it might waste your time by 1 month by healing time. When you give chemotherapy, that time the small cells may go into your lungs and bone, may increase in size. That's why sometimes doctors will prefer you to give chemotherapy first and then surgery second. So this is how we take initial treatment plan actually. After the surgery, then you will have radiotherapy depending on the involvement of your breast and the lymph. And then it will be the hormone therapy. Hormone therapy is for 5 years, 10 years, depending on your nature of the tumor and the advice according to your age also. So once these are all done, most of the time, like stage 1, we have 95% survival rate. Stage 2, 80 to 90% survival rate. Stage 3, more than 70%, but they require all the modalities: surgery, chemotherapy, radiotherapy, everything. Stage 1 and 2, most of the time you might go only with surgery and chemotherapy, or one with surgery. And with the follow-up, we will usually follow up 3 monthly once first year, 6 monthly once second year, and early ones till 5 years. Then after that, it depends on patient and doctor's relationship, how they want to supply. Thank you.
Thank you, Doctor. Sorry, because of time, I will let Ms. Anu ask a question. Yeah, go ahead.
There was one aspect that we've not spoken about here, and that's about cervical cancer. I mean, breast cancer is something that many people are quite aware of. But cervical cancer, they say that there are hardly any symptoms. So how do we ensure that we can prevent this from happening?
Prevention is by vaccine. The main prevention is by vaccine. So we have a vaccine available with even 9 variants are available. So it is the best way of preventing. It has to be started with 12 years of age. 12 to 14 is the ideal age to start the vaccine, not after the marriage or after the first intercourse. So that's why we prefer always in the teenage time. When they attain puberty, it is the time to start vaccination. So, and that is the prevention part. And then for early detection, we have pap smear. From 21 years onwards, you have to do the pap smear. So it's 21, not 40 or not 35, it's 21. So from that time onwards, we start, because the commonest age is 35 to 45 for the cervical cancer, very early actually to get it. And first symptoms, if you see the pathognomonic, we call, but most of the people will know, but they are very shy to tell us the bleeding during the intercourse, post-coital bleeding. That is the sign actually, which will tell you might have a cervical cancer. But most of the people neglect or will try to avoid it actually.
Thank you, Doctor. We cannot tell too often the fact that cancer is curable and early detection is always the key. We have to tell this again and again. Please, please always monitor yourself so that we can avoid such problems in future. Thank you so much, Doctor.
Thank you, Dr. Shivprakash. I think you hit on the few pointers for all of us to remember, that vaccine at the age of, when attaining puberty is a must if you are looking at preventing. If not, it doesn't work, if anything, beyond 20 years, as well as regular pap smears would start right at the beginning of 21 years. I think that's the takeaway messages that we got from you. Thank you so much, Doctor, especially because you took your time to be with us and come be in our studio as well and join us for the entirety of the session. We're really grateful for that. Moving on to Aster Bangalore, where we have, we're joined by Dr. Sonal Asthana. Dr. Sonal Asthana is our lead consultant of hepatopancreatobiliary and our transplant surgeon. He is working at Hebal Aster CMI and has acquired huge knowledge in the field of close to 2 decades of expertise as a hepatopancreatobiliary and a multi-organ transplant surgeon. He completed his MBBS and his MS from JIPMER in Pondicherry and MRCS from the Royal College of Surgeons, Edinburgh. He went on to do his MSc from the University of Alberta in Canada and fellowship in multi-organ transplantation from the American Society of Transplant Surgeons from Edmonton in Canada. He has wide experience in performing transplant surgeries of liver, kidney, pancreas, clinical islet cell transplant, and surgical management of diseases of the liver, gallbladder, and biliary tract. It is my honor and privilege to have Dr. Sonal here. I'm sure he has a very busy schedule and multiple transplants to do. But thank you so much for joining us, and over to you, sir.
Thank you so much for that very kind introduction, and it really is a pleasure to be here. And at the outset, I'd like to thank you all for the invitation and also congratulate you, compliment you on the good work. Aster Volunteers has really become a force to reckon with, and we follow your achievements with great pride as being part of the Aster community. So my mandate today is to talk a little bit about liver cancer. And I chose a topic which perhaps is a little bit, hopefully a little bit controversial or thought-provoking. That's.
We're not able to see your screen yet, Doctor. I think
Okay.
we'll give it a minute.
Is that visible now?
Not yet, not yet.
Okay. So let me try something else. I'll,
Maybe you
share
can
the
just,
screen.
yeah, it's come now. It's there. We can see it. But I
Okay.
think the slideshow was not working. So you might want to go to the next.
Full screen isn't working, isn't it?
Yeah.
Oh, does it work now?
It's gone. We don't have the slideshow, but it was there previously.
All right, we'll just do this another way.
Yeah, we can just do this.
It's okay. Let me try that. Share my desktop. So then it becomes a little easier to do. How about
Yeah,
now?
we're on. Yes, absolutely. Go ahead.
Perfect. Okay, so I mean, in terms of declarations, most of my declarations are academic. Apart from my role as hepatobiliary surgeon and multi-organ transplant surgeon at Aster, I'm also an adjunct professor at the Indian Institute of Science at Bangalore Medical College, and I hold certain technical and regulatory responsibilities related to transplant in regional and national bodies. I'd like to thank my colleagues, Dr. Karthik, Dr. Asima, Dr. Srinivas and Charles, who have actually helped me in putting this presentation together. So, hepatocellular carcinoma, probably there are a few things to know. It is one of the commonest cancers of your liver. So the liver is probably the unsung hero of the body. It is the largest organ of the body. It is almost 2% of the body weight, and it sort of is considered to be the engine of the body because of all the work that it does in producing all the enzymes, digesting food, as well as removing toxins from the body. So a damage of the liver is bad news, and the damage of the liver, which happens chronically for various reasons, which we will talk about, is called cirrhosis. So invariably what happens is that lots of hepatocellular carcinomas that occur in the liver actually occur in patients who already have damaged livers because of various reasons. So when you're treating or when you're talking about hepatocellular carcinoma, it's important that we're talking about not one disease, but two. We're talking about the cancer itself, but we're also talking about the organ in which the cancer is occurring, which may be damaged. So why is it important to know about hepatocellular carcinoma? For one, that it's very common in certain parts of the world that come to us for treatment, as well as our own part of the world. The reasons for this commonality are a little bit different. For example, we can see that China is dark blue in color, which indicates a very high rate of cancer. That is predominantly because of infections related to hepatitis B. The same with Africa, as you can see here. The reasons in North America are very, very different. They're related to non-alcoholic steatohepatitis, or fatty liver disease, as we call it, which is emerging as a very large or very prominent indicator as a precursor of carcinoma. So firstly, it is very common. Secondly, it is increasing in number. And thirdly, probably for the most important reason, is that we are not winning when it comes to hepatocellular carcinoma. As you can see in this graph, the decrease in mortality over the last 20 years, that's sort of mapped out here. You can see that most cancers have actually, you've done very well in most cancers, in cervical cancer, ovarian cancer. There have been significant gains in life and in function over the last 10 or 15 years. and the mortality has decreased. But when it comes to especially liver and bile duct cancers, lung cancers, that is in fact not the case, and our mortality has increased. So it becomes important for us to understand what causes this cancer and treat it early. So as mentioned before, most cancers occur in damaged livers. The cause of liver damage is very different in different places. The liver damage causes in Asia and Africa related to infection. Hepatitis B and hepatitis C causing the predominant parts of the infection. And the other emerging factor, which is an important part for all of us, fatty liver or non-alcoholic fatty liver disease. People who have obesity, people who have diabetes and fatty liver associated with this are also at risk for developing liver cancer. And this, in fact, is the fastest growing group of liver cancer in our patients today. So, I think the first slide that I should have put up here about symptoms is nothing. Most patients with hepatocellular carcinoma do not have any symptoms, which makes it very, very difficult to detect. As you probably know, because of the liver is very renowned for its regenerative capacity. So it, in fact, it would take almost 70 to 80% of the liver to be damaged before any symptoms occurred, which is very good from the body's point of view, because certainly the liver is a very durable organ. But it also means that if any disease is present, we end up detecting them much later in life. So most hepatocellular carcinomas do not have any specific symptoms, but normally when they present to us in an advanced form. And how can they present? They present with loss of appetite, nausea, weight loss, abdominal pain, jaundice, itching and swelling of the abdomen. Can we actually prevent hepatocellular carcinoma? So as you mentioned, as you must have seen, I've discussed infection as being a very important part. Equally, diabetes and fatty liver, which are lifestyle diseases, are also important parts of this. So certainly these are things that can be included as part of a healthy lifestyle. So part of it obviously is universal vaccination against hepatitis B infection. This is part of the universal immunization program now in both in Dubai as well as India. So most children born after 2000 have received a hepatitis B infection. So hopefully we will see the end of this scourge in our country very soon. The other is antiviral therapy. We have very good antiviral therapy for hepatitis B and C, and that can be started as soon as patients are detected. Certainly, when we talk about policy implementations, when we talk about, say, safe sex, making sure that needles are not reused in hospitals, etc., these are policy things that can decrease the amounts of infection. Avoidance of alcohol, avoidance of smoking, control of weight, in a healthy lifestyle and control of diabetes are all things that can prevent damage associated with non-alcoholic or fatty liver disease, which can predispose to cancer. And there are certain interesting things. Coffee consumption is one of those things that has been shown to reduce the incidence of hepatocellular carcinoma. So I drink a lot of coffee, so I think I'm going to be safe. And certainly we have seen more and more papers coming out which show that things like aspirin, things like coffee, things like statins, which are given for cholesterol, can all decrease the degree of liver inflammation and consequently, tumor formation. So can we check for the cancers? We've talked about surveillance in certain other cancers. I'm sure we've discussed cervical cancer and breast cancer. But certainly, we know that hepatocellular carcinomas predominantly occur in patients who have damaged livers. So patients with cirrhosis typically should be scanned on a regular basis, once every 6 months at least, and they should undergo a blood test, which is called an alpha-fetoprotein, which is a tumor marker, which tells us which patients might have a hepatocellular carcinoma. So basically, if there are very small lesions, sometimes you see lesions that are less than 1 centimeter, they can be followed up. And lesions that are larger can basically be imaged using more invasive methods such as CT or MRI. And in fact, a CT or an MRI is a diagnostic method for hepatocellular carcinomas. So hepatocellular carcinoma is already a disease of the future, in that we do not need to biopsy most of these tumors to come up with a diagnosis. A CT scan or an MRI scan done in the proper way, as you can see here, the tumor is lighting up when we give the contrast and then washes out, leaving a rim of contrast around. in later scans. This kind of feature is so pathognomic that it is able to diagnose tumors that are more than 2 centimeters with 95% accuracy. So most of the time, we do not need to do transplant or biopsies for patients with hepatocellular carcinoma. And when do we do biopsies? Nowadays, it's very paradoxical that we do biopsies not for proving a diagnosis, but for obtaining genetic material to test tumors to see whether they can respond to newer diseases which target certain specific genes. So if you remember, we initially talked about hepatocellular carcinoma being not one disease, but 2 diseases. One is the disease, the cancer, and the second is the disease of the liver. So certainly when we talk about staging or deciding how these patients will do, we have to think about both those things. So we talk about not just the stage of the cancer, the grades, which you must be familiar with, as you've heard, as with most standard cancers, but we also talk about the performance status of the patient. Is the patient active? Is the patient bedridden? Is the patient in hospital? And also the liver status, which is measured by something called the child score. So certainly when we look at all of these things, the tumor is one part of it, but we also have to see whether the patient is healthy enough to undergo treatment, and if the liver is strong enough for us to sort of treat it aggressively. So what are the treatment options? There are several treatment options which are available, and I'd like to break them up using a popular series from not too long ago. So you can treat it either by fire, ice, sword, or poison. So when we talk about fire, we can actually burn the tumor. That is by something called a radio frequency ablation, or an RFA. You can also burn the tumor using microwave. You can burn the tumor using targeted radiotherapy, such as SIRT, or high frequency ultrasound, which is the HIFU. We can also freeze a tumor by using a special probe that goes inside the tumor and then freezes the tumor as a sort of a ball, which is called cryoablation. This treatment has fallen out of favor because it's not nearly as effective as killing all tumor cells, but it is still used in certain tumors. The other thing you can do is actually use the sword, where you can either remove the tumor in its entirety and with a part of the liver, or you can remove the liver altogether, where we actually change the damaged liver and we replace it using a transplanted liver. So transplantation is another treatment option that can be offered. And the last one is poisons, which basically is nothing but chemotherapeutic agents which are given in a very targeted fashion. So we can actually inject ethanol into the tumor, which actually can kill very, very small tumors up to 2 centimeters. We can treat it with targeted chemotherapy, which is called TACE, which I'll talk about. And the other is giving tablets which target certain gene mutations. These are therapies which are called tyrosine kinase inhibitors, which have actually become very common. There are other newer agents which are called immunomodulators, which use the body's own immune system to target the liver, the tumors, and prevent them from growing. So just to give you one example, this is a patient who had a large tumor of the liver on one side. This is what we found when we operated on the patient. As you can see, very, very unhealthy looking tumor. And this is what happens when you remove the tumor along with the margin of the liver, so that you are sure that all the tumor has been removed in its entirety. The other therapy, as we talked about, was something called TACE, which is a very, very targeted form of chemotherapy. If you think about chemotherapy as carpet bombing, where we are using some drugs that spread all over the body and that destroy not just the tumor cells, but many of the healthy cells, then this is targeted therapy. This is like a guided missile, where we actually introduce a small plastic tube into the blood vessel, directly going into the liver, where the chemotherapeutic agent can be given directly inside the liver into the tumor, and where it acts only on the tumor and doesn't spread inside the rest of the body and cause the side effects of chemotherapy. And this is basically what it looks like when you can actually put a small catheter, as you can see here, going directly into the tumor, and you inject a chemotherapy mixed with an agent called lipoidol, which actually stays inside the tumor. You can see that there's a nice accumulation of all of this inside the tumor. So then when we break it up into treatment options, you're familiar with this chart when we talk about not just the liver, but we talk about the tumor, we talk about the functional status of the patient. So when we talk about a very early stage of tumor, very small tumors, we can actually ablate them using microwave therapy or radiofrequency ablation, or we can remove the tumor along with a part of the liver. Some of these patients can also benefit from a transplant. When we talk about early stage, when we talk about say 1 or 2 nodules, which are all less than 3 centimeters in size, again, we have those 2 options of either burning the tumor out or transplanting it by changing the whole liver. All of these have a very nice long-term survival. When we move on to intermediate liver, which basically means that either the tumor is larger, a bad tumor, or a bad or marginal liver, then we can talk about either TACE therapy or we could talk about systemic therapy. And you can see that the difference in survival is very significant, right? So when we look at something with curative therapy, or when we look at something with non-curative therapy intent, the survival rates are very, very different. And if you have patients, unfortunately, a lot of our patients present to us with bad tumors and bad livers, very large tumors with poor liver function. Unfortunately, all we can do is give them supportive care. And the median survival is very low, which is about 3 months. So to summarize my talk, hepatocellular carcinoma is a leading and growing cause of cancer-related mortality. Fatty liver disease is an emerging factor that increases the risk of this and diabetes. And so that's why we all should worry about it, because this is something that is related to lifestyle and can be attenuated or controlled well if you're able to manage the risk factors well. If we detect these cancers early, we can treat them well. You can see that survival is actually very good if these tumors are picked up early. These tumors can be detected without doing a biopsy. For the most part, if you do a good multi-phase CT or a dynamic contrast MRI. We have a very standard staging system, which includes not just the staging of the cancer, but also an indicator of what is a good therapy, which is called the Barcelona clinic system, which is what I showed you in the last slide. Early cancers can be treated equally well with surgery or ablation therapy. And if the treatment of the tumor, which is a little bit advanced, or the liver, which is weak, then we can talk about systemic therapy, TACE, etc. This is just a breakup of the Barcelona therapy, as we've just discussed. I went over it so just one slide ago. I'm going to leave it on for a second, just so that you can see the difference between what curative therapy can do and what non-curative therapy does.
Thank you, Dr. Sonal.
Yeah. So essentially, all these, on all these patients, I'm just winding up.
Sure,
we basically
please.
need to assess them well. We need to individualize treatment. There are multiple treatment options available, and certainly based on the kind of patient we have, kind of tumor we have, we can give them the most optimal therapy possible. Thank you so much for your attention.
Thank you so much, Dr. Sonal. That was really very elaborate and clear. I would like to ask, since you are our clinical lead and program director for the multi-organ transplant surgery, as well as the Aster integrated liver care, what are the challenges that you would see commonly when it comes to liver transplants in India?
So essentially, there are, if I break them up into 2 parts, the first would be that patients with liver disease present much later in India as compared to what our colleagues in the West see. There are several reasons for it. One is, as we mentioned, liver disease is usually asymptomatic for a very large part of its course. So it isn't until the liver is damaged to about 70 to 80% that people actually develop symptoms. And secondly, because of a lack of appropriate guidance and a lack of understanding of the severity of liver disease, many people are treated by sort of in general practice for several years before they actually are referred to us. By that time, they're very malnourished or they have advanced cancer, and we are not able to help them. So firstly, that we probably need to educate not just patients, but our own colleagues to ensure that liver disease, advanced liver disease, is identified early and referred appropriately for management, just in case some of these require transplant. The second problem is, of course, the availability of donors, because deceased donor transplants in India are still relatively new. Although we have had the law for 25 years, we have had donations now predominantly picking up in the south and the west of the country. But still, the number of donors are much less than the number of donors that are required. For example, we have less than 1,000 donors in our country, and more than 50,000 people may require liver transplant every year.
That's interesting statistics. Do you have any questions?
Something very small, very fast.
Yeah.
Sir, my name is Anup. I'm from the All Kerala Colleges Alumni Forum. We have a predominantly male population out here. So my question is related to that, because we always have related the, so you're already smiling. So that's exactly my point. We have predominantly always said the liver cancer is always associated with the alcoholism, or the intake of alcohol being muchly higher, or the smoking rather. So now you are saying the non-alcoholic cirrhosis, it's also catching up as one of the major reasons. So is it important, still the same level of importance for the alcoholism is attached to this particular cancer, or there are so many other things that are also coming up? Because I'm also seeing from the statistics, male population are generally much higher affected. So is there a specific reason other than the alcoholism and smoking?
Sure. Firstly, I think in your own panel, you're in a bit of a minority. So I'm not sure about the male-female distribution. So the other thing is that, you are right about alcohol being a cause of liver damage and consequently a cause of liver cancer, because cancers arise in damaged livers. But the other thing to remember is that cancers that arise from fatty livers are a slightly different breed, because cancers can arise in fatty livers before they become cirrhotic. Okay. So the same thing with diabetes. When diabetes is present for say 15 or 20 years, we may have patients who have moderate fatty liver, which has not progressed to cirrhosis, but these patients can still develop cancers. So they have a different trajectory of presentation. They have a different timing of presentation. And I guess to probably put the two things together, the additive effects of these are not 1 + 1. For example, if you have say moderately to severe fatty liver and you also consume alcohol, it's not like your risk increases 2 times. It increases 5 to 6 times. Because you're putting a damaged liver under more pressure by drinking alcohol. Okay, so I think that so I guess it's fairly bad news for people who are obese, who are diabetic, who are also have a moderately fatty liver, because certainly our recommendation for them right now is to not drink at all if you can help it.
Thank you, Doctor.
Thank you so much, Dr. Sonal, for taking us through the liver transplants. And though I have many questions, I will save it for another day. And I'm sure my fellow panelists here as well would have lots, because transplant is an area that we don't get the opportunity to talk too much about. So we got a lot of information today, and we thank you for your valuable time and joining us. With that, we have come to the end. Thank you. With that, we come to the next part of our session, where we thank all our speakers and move on to releasing packages both in UAE as well as in India. We will be at this point, we're also joined by Mr. Farhan, who's our regional CEO for both the India Kerala cluster as well as Oman, I will shortly invite him to talk and release from India. We would like to release the UAE. Dr. Sharbaz is not here, unfortunately, but on his behalf, Dr. Sharbaz, our CEO of Aster Hospitals and Clinics in the UAE, would like to release our packages for cancer prevention in the UAE for February and March. We have these special packages which will be on your screen and can be availed for all our for the public throughout the months of February and March. Yeah, so I think you can see in pink is the packages that are out there, which was the early detection oncology screening packages for both the males and females at different ages and at a reduced cost. We urge everyone to please go and make use of these packages to help prevent cancer. Early detection saves lives. With that, I invite Mr. Farhan, our Regional Director of Kerala Cluster and Oman's Aster Hospitals from India. Thank you so much, Mr. Farhan, for joining us. Over to you.
Thank you very much for giving this opportunity. And for us, Akcaf is so important and it's close to our heart. So we used to serve, we would like to serve their family members. Akcafile in the UAE ജോലി ചെയ്യുന്ന അല്ലെങ്കിൽ UAE പ്രവർത്തിക്കുന്ന അവരുടെ കുടുംബാംഗങ്ങൾക്ക് വേണ്ടിയാണ് ഇത്തരത്തിലൊരു പാക്കേജുമായിട്ട് നമ്മൾ മുന്നിട്ട് വരാൻ ആഗ്രഹിക്കുന്നത്. കേരളത്തിൽ നിങ്ങൾക്ക് എല്ലാവർക്കും അറിയാം, നമുക്ക് കൊച്ചിൻ ആസ്റ്റർ മെഡിസിറ്റി, കോഴിക്കോട് ആസ്റ്റർ മിംസ്, കോട്ടക്കൽ ആസ്റ്റർ മിംസ്, കണ്ണൂർ ആസ്റ്റർ മിംസ്, വയനാട് നമുക്ക് വിംസ് മെഡിക്കൽ കോളേജ്, വയനാട് ഇൻസ്റ്റിറ്റ്യൂട്ട് ഓഫ് മെഡിക്കൽ സയൻസ് മെഡിക്കൽ കോളേജ് ഉണ്ട്. ഇവിടെ എല്ലായിടത്തും നമ്മളൊരു കോംപ്രിഹെൻസീവ് ക്യാൻസർ സ്ക്രീനിങ് പ്രോഗ്രാമാണ് നമ്മൾ ഉണ്ടാക്കിയിരിക്കുന്നത്. അതിൽ നമ്മൾ 3 കാറ്റഗറി ആയിട്ട് ഫീമെയിൽ 40+ എബോവ് ഉള്ള ആൾക്കാർക്ക് ക്യാൻസർ ഉണ്ടോ എന്ന് തിരിച്ചറിയുക, മാമോഗ്രാഫും അൾട്രാസൗണ്ട് അബ്ഡമൻ ഉൾപ്പെടെയുള്ള ഒരുപാട് ഇൻവെസ്റ്റിഗേഷൻസ് വെച്ചിട്ട് ഒരു പാക്കേജ് ഉണ്ടാക്കിയിട്ടുണ്ട്. ഇതിന്റെ ഒരു ഗുണം എന്താണെന്ന് വെച്ച് കഴിഞ്ഞാൽ നമുക്ക് മുൻകൂട്ടി ഇത് അറിയുകയും ഇത് ഏറ്റവും അതിന്റെ വഷളായ അവസ്ഥയിൽ എത്തും മുന്നേ ചികിത്സിച്ച് ഭേദമാക്കാൻ പറ്റുന്ന രീതിയിൽ നമുക്ക് ചെയ്യാൻ പറ്റുന്നതാണ് ക്യാൻസർ എന്ന അസുഖം. അപ്പൊ നേരത്തെ മുൻകൂട്ടി കണ്ടുപിടിക്കുക. നമ്മൾ പലരും ശ്രദ്ധിക്കപ്പെടാണ്ട് പോകുന്ന പല കാര്യങ്ങളും നമ്മുടെ ജീവിതത്തിലുണ്ട്. അത് ഇത്തരത്തിലൊരു ദിവസം, ഒരു അര ദിവസം ചെലവാക്കി കഴിഞ്ഞാൽ അത് നേരത്തെ കണ്ടുപിടിക്കാൻ പറ്റുന്നതേ ഉള്ളൂ. അതിനുവേണ്ടി സൗകര്യം നമ്മുടെ എല്ലാ ആശുപത്രിയിലും ഒരുക്കിയിട്ടുണ്ട്. അത് മാത്രമല്ല, അക്കാഫിലെ ഏതൊരു അംഗങ്ങൾക്കും നമ്മളെ തന്നെ നേരിട്ട് വിളിക്കാനുള്ള പേഴ്സണൽ നമ്പേഴ്സ് അടക്കം നമ്മൾ കൊടുക്കുന്നുണ്ട്. വിളിക്കുക, വിളിപ്പുറത്ത് നമ്മളെല്ലാവരും ഉണ്ടാവും. ആ ബന്ധം നിങ്ങൾ അവിടെ അധ്വാനിക്കുമ്പോഴും നിങ്ങളുടെ കുടുംബാംഗങ്ങളെ നോക്കുക എന്നൊരു ദൗത്യം കൂടി നമ്മൾ മുന്നിട്ട് വെക്കുന്നുണ്ട്. താങ്ക് യു വെരി മച്ച്.
Over to you, Anu.
Thank you so much, Dr. Farhan, for treating Akcaf as a part of your family. You are the healthcare giants, and to have a partnership with you is definitely a blessing for us. And we've got 2 of our officials here online, and we would like to invite them. Anup.
Thank you very much. നമ്മുടെ ഭാഗത്തു നിന്നും അക്കാഫ് എന്നും ആസ്റ്ററുമായി കുറച്ചു കാലങ്ങളായിട്ട് വളരെ അടുത്ത് പ്രവർത്തിച്ചുകൊണ്ടിരിക്കുകയാണ്. അപ്പോൾ ഇത്രയും മനോഹരമായ പാക്കേജുകൾ നമുക്ക് തന്നതിന് ഒരുപാട് നന്ദി. നമ്മൾ സ്നേഹിക്കുന്നവർ നമ്മളോടൊപ്പം ഇല്ലെങ്കിൽ പോലും അവരുടെ ആരോഗ്യം സംരക്ഷിക്കാൻ ഞങ്ങൾക്ക് ഒപ്പം നിൽക്കുന്നതിന് ഒരുപാട് സന്തോഷം. ഇനി അക്കാഫിന്റെ ഭാഗത്തുനിന്നും നിങ്ങളോട് ഇത്രയും കാര്യങ്ങൾ ചെയ്തതിനും നന്ദി പറയുന്നതിനും ഒക്കെ ആയിട്ട് നമ്മളുടെ പ്രിയപ്പെട്ട ചെയർമാൻ മിസ്റ്റർ ഷാഹുൽ ഹമീദിനെ നിങ്ങളോട് എല്ലാവരോടും 2 വാക്ക് പറയാനായിട്ട് ഞാൻ ക്ഷണിക്കുകയാണ്. ഷാഹുൽ.
ആദ്യമായിട്ട് എല്ലാവർക്കും ഞാൻ നന്ദി പറയുകയാണ്. തീർച്ചയായിട്ടും വളരെ ഇത്തരത്തിലുള്ള ഒരു വെബിനാർ ഞാൻ ആദ്യമായിട്ടാണ് ഞാൻ എൻ്റെ UAE ലൈഫിൽ കേൾക്കുന്നത്. കാരണം ഇവിടെ നമ്മൾ ഇതിനെക്കുറിച്ച് ലിവർ ക്യാൻസറിനെ കുറിച്ച് ഡോക്ടർ സോണൽ അസ്തമ പറഞ്ഞിരുന്നു. അതുപോലെ തന്നെ നമ്മളെ തൈറോയ്ഡ് ക്യാൻസറിനെ കുറിച്ച് ഡോക്ടർ ഗീത പൈ പറഞ്ഞു. അതുപോലെ ഡോക്ടർ കേശവൻ ചൈൽഡ്ഹുഡ് ക്യാൻസറിനെ കുറിച്ച്, അതുപോലെ തന്നെ ഡോക്ടർ ശിവപ്രസാദ് ബ്രസ്റ്റ് ക്യാൻസറിനെ കുറിച്ചും, അതുപോലെ ഡോക്ടർ കിഷോർ പ്രോസ്റ്റേറ്റ് ക്യാൻസറിനെ കുറിച്ചും. അപ്പോൾ എല്ലാ മേഖലയിലുള്ള ഈ ക്യാൻസർ അവയറിനെ കുറിച്ച് നല്ല ഒരു സെമിനാറാണ്, നല്ല ഒരു അവതരണമാണ് ഇത് 5 ഡോക്ടേഴ്സും അത് നൽകിയിട്ടുള്ളത്. തീർച്ചയായിട്ടും നമ്മൾ ഏതൊരു അസുഖമാണെന്നുണ്ടെങ്കിലും ഏർലി, നമ്മുടെ ഈ തീം തന്നെ വളരെയാണ്, ഏർലി പ്രൊട്ടക്ഷൻ ആൻഡ് പ്രിവെൻഷൻ. ഇപ്പൊ സാധാരണ മറ്റ് രോഗങ്ങളാണെന്നുണ്ടെങ്കിൽ നമുക്ക് ഇപ്പൊ ഒരു പനിയോ ഒരു ചുമയോ ഒരു തലവേദനയൊക്കെ ആണെന്നുണ്ടെങ്കിൽ നമുക്കത് ആ അസുഖം നമുക്ക് ഏത് സമയത്ത് അത് ചികിത്സിച്ച് അത് മാറ്റാം. ഇത് ഡോക്ടേഴ്സ് പറഞ്ഞതുപോലെ ഈ ക്യാൻസറിന്റെ ഏറ്റവും വലിയ ഒരു നമ്മുടെ അവയർനെസ്, ഈ ഏർലി ഡിറ്റക്ഷൻ എന്ന് പറയുന്നത് ഫസ്റ്റ് സ്റ്റേജിലാണെന്നുണ്ടെങ്കിൽ നമ്മൾ ഏത് ക്യാൻസർ, അപ്പം ലിവർ ക്യാൻസർ ആയാലും അല്ലെങ്കിൽ തൈറോയിഡ് ക്യാൻസർ ആയാലും അല്ലെന്നുണ്ട് ബ്രസ്റ്റ് ക്യാൻസർ ഏതായാലും തന്നെയും നമുക്ക് ആ ഫസ്റ്റ് സ്റ്റേജിൽ ചെന്ന് നമുക്കത് ട്രീറ്റ്മെന്റ് നടത്തുകയാണെന്നുണ്ടെങ്കിൽ ഏകദേശം 90% കൂടുതൽ നമുക്ക് സർവൈവൽ ഉണ്ട്. അപ്പൊ അതിൽ നമുക്ക് മനസ്സിലാക്കേണ്ടത് തീർച്ചയായിട്ടും നമുക്ക് ഇപ്പം തന്നെ ഇത് നമ്മുടെ ഫർഹാൻ യാസിൻ നമുക്ക് നല്ലൊരു സ്കീം നമ്മുടെ മെമ്പേഴ്സിന് വേണ്ടി തന്നിട്ടുണ്ട്. തീർച്ചയായിട്ടും നമ്മുടെ ആൾക്കാർ, നമ്മുടെ അക്കാഫിന്റെ ഇവിടെയുള്ള മെമ്പേഴ്സ് തീർച്ചയായിട്ടും ആ സ്കീം അവൈൽ ചെയ്തിട്ട് നമ്മൾ ഇയർലി, അതായത് ആദ്യം തന്നെ നമ്മൾ ഇതിന്റെ ഒരു ഏർലി സ്റ്റേജിൽ തന്നെ നമ്മൾ ഇതിന്റെ ഒരു ടെസ്റ്റിംഗ് ഒക്കെ നടത്തുകയാണെന്നുണ്ടെങ്കിൽ നമുക്ക് ഈ ക്യാൻസർ എന്ന ഈ മഹാമാരിയിൽ നിന്ന് നമുക്ക് നമ്മുടെ ജീവൻ രക്ഷിക്കാൻ സാധിക്കും. അപ്പൊ അതിൽ നിന്ന് എനിക്ക് പറയാനുള്ളത്, തീർച്ചയായിട്ടും നമ്മുടെ അക്കാഫിന്റെ മെമ്പേഴ്സ് ഈ തന്നിരിക്കുന്ന ഈ ഡിസ്കൗണ്ട്, അപ്പോൾ അത് 2 മാസത്തേക്കാണ്, അത് നമ്മൾ അവൈൽ ചെയ്യുകയും നമ്മുടെ ഫാമിലിയെ, നമ്മളെ കുടുംബത്തെ എല്ലാം നമ്മൾ അതിൽ നിന്ന് രക്ഷിക്കണം. അതുപോലെ തന്നെ നേരത്തെ തന്നെ ഒരു സ്കീം നമുക്ക് അവർ തന്നിട്ടുണ്ടായിരുന്നു. അത് ദിൽസേ സ്കീം. ആ ദിൽസേ സ്കീമിൽ തന്നെയും ആനുവൽ ഹെൽത്ത് പാക്കേജസ് ഫോർ എക്സ്പയർസ് ഫാമിലീസ് ആണ്. ആ സ്കീമും അത് മാർച്ച് വരെ ഉണ്ട് എന്നാണ് ഞാൻ അറിഞ്ഞത്. തീർച്ചയായിട്ടും നമ്മുടെ പേരൻസ് അല്ലെങ്കിൽ നാട്ടിലുള്ള നമ്മുടെ പേരൻസ് ഇല്ലാത്ത ആൾക്കാരാണെന്നുണ്ടെങ്കിൽ നമ്മുടെ കുടുംബത്തിൽപ്പെട്ട ആൾക്കാർക്കോ അല്ലെങ്കിൽ നമ്മുടെ ഫ്രണ്ട്സിനോ അല്ലെങ്കിൽ ഇതൊന്നും അല്ലാത്ത ഒരാൾക്ക് വേണമെങ്കിലും നമുക്ക് അത് എടുത്തു കൊടുക്കാൻ പറ്റും. അതും ഒരു വർഷത്തെ ഒരു പാക്കേജ് എന്ന് പറയുന്നത് 5,000 ഇന്ത്യൻ റുപ്പീസും ഇവിടുത്തെ ദറമാണെങ്കിൽ 250 ആണ്. തീർച്ചയായിട്ടും അതിനാണെന്നുണ്ടെങ്കിൽ ആദ്യം അതിന്റെ ഒരു ചെക്കിംഗ് ഉണ്ട്. NRI can avail on annual packages of ₹5,000 per family member. It includes an initial health checkup for each family member enrolled to ascertain their health in the beginning. അതാണ്. അപ്പൊ നമുക്ക് ഏറ്റവും കൂടുതൽ ബിഗിനിങ്ങിൽ നമുക്ക് നമ്മുടെ ഹെൽത്ത് ഒരു അവയർനെസ് ഉണ്ടാകുവാണെങ്കിൽ തീർച്ചയായിട്ടും നമ്മുടെ ഫാമിലികളെയൊക്കെ നമുക്ക് സംരക്ഷിക്കാൻ പറ്റും. ഇപ്പൊ നമുക്കറിയാം പലപ്പോഴും ഉള്ളത് നമ്മുടെ പേരൻസും അല്ലെന്നുണ്ട് റിലേറ്റീവ്സ് നാട്ടിലുണ്ടെന്നുണ്ടെങ്കിൽ മിക്കവാറും അവരിപ്പോ നമ്മളെന്തെങ്കിലും വിളിച്ചു കൊടുത്ത് സംസാരിക്കുകയോ ചെയ്താൽ പറയും അത് കുഴപ്പമില്ല. പ്രത്യേകിച്ച് അവര് നമ്മളെ വിഷമിപ്പിക്കേണ്ടെന്ന് വിചാരിച്ച എന്തെങ്കിലും ചെറിയ അസുഖങ്ങൾ ഉണ്ടെങ്കിൽ തന്നെയും അവര് കുഴപ്പമില്ല എന്ന് പറയും. ഇങ്ങനെ ഒരു സ്കീം ഉണ്ടെന്നുണ്ടെങ്കിൽ ഇമ്മീഡിയറ്റ് ആയിട്ട് നമുക്ക് 24/7 സർവീസ് ഉണ്ട്. ഉടൻ തന്നെ അവര് നമ്മുടെ വീട്ടിലെ ഡോക്ടേഴ്സ് അല്ലെങ്കിൽ എത്തുകയും അവരെ അതിന്റെ ഇനിഷ്യൽ ചെക്കപ്പ് നടത്തി ഏതെങ്കിലും അസുഖം ഉണ്ടെങ്കിൽ നമുക്ക് ഡിറ്റക്ട് ചെയ്യാൻ പറ്റും. അതുകൊണ്ട് ആ ദിൽസേ എന്ന് പറയുന്ന ആ സ്കീമിലും നമ്മുടെ ആൾക്കാർ അക്കാഫിന്റെ മെമ്പേഴ്സ് ഇനി വൈകിട്ടില്ല, അതിൽ മെമ്പർഷിപ്പ് എടുക്കണമെന്ന് ഞാൻ പറയുകയാണ്. തീർച്ചയായിട്ടും നല്ല അക്കാഫും പിന്നെ നമ്മുടെ ആസ്റ്റർ വോളണ്ടിയേഴ്സ് തമ്മിൽ കഴിഞ്ഞ ഒരു വർഷമായിട്ട് പ്രത്യേകിച്ച് നമ്മുടെ മരണപ്പെട്ടു പോയ നമ്മുടെ അഷ്റഫ്, അപ്പൊ അതിന്റെയും കൂടെ ഒരു അവയർനെസ്സിന് വേണ്ടിയാണ് നമ്മളിപ്പോ ഈ ക്യാൻസർ അവയർനെസ്സിൽ നമ്മുടെ ഈ ഇന്നത്തെ ഒരു സെമിനാർ നടത്തിയത്. ഒരു 47ാമത്തെ വയസ്സിൽ അദ്ദേഹം മരണപ്പെട്ടു. ഇന്ന് നമ്മുടെ ഈ അക്ക ഫാമിലിയിൽ നിന്നും അങ്ങനെ ഒരാൾ മരണപ്പെടാതിരിക്കാൻ വേണ്ടി നമ്മുടെ ആൾക്കാർ ഈ അവയർനെസ്സിൽ, അതായത് ഈ സ്കീം എടുത്ത് ക്യാൻസറിന്റെയും അതുപോലെ നമ്മുടെ നാട്ടിലെ ദിൽസ എന്നുള്ള സ്കീം എടുത്ത് ഇവരുമായിട്ട് നമ്മൾ ആസ്റ്റർ വോളണ്ടിയേഴ്സുമായിട്ട് നമ്മൾ സഹകരിക്കുമെന്ന് അഭ്യർത്ഥിക്കുകയും ഇന്ന് ഈ സെമിനാർ നടത്തിയ എല്ലാ ഡോക്ടേഴ്സിനെയും അവർ മുക്തമുണ്ട് ഞാൻ പ്രശംസിച്ചുകൊണ്ടും ആസ്റ്റർ വോളണ്ടിയേഴ്സ് ഈ ടീം നമുക്ക് വേണ്ടി ചെയ്യുന്ന എല്ലാ സഹായങ്ങൾക്കും നമ്മുടെ ജലീലും പിയും നമ്മളെല്ലാവരും ഈ ഒരു ടീമായിട്ട് തന്നിട്ടുണ്ട്. അതുപോലെ നമ്മുടെ ഫർഹാൻ യാസിൻ എല്ലാവരും നമ്മുടെ ഈ സഹായിക്കുന്നുണ്ട്. അതുപോലെ ഒരു ടോൾ ഫ്രീ നമ്പർ വരെ നമുക്ക് തന്നിട്ടുണ്ട്. എല്ലാവരും ഈ സ്കീം അവൈൽ ചെയ്യണമെന്ന് അഭ്യർത്ഥിച്ചുകൊണ്ട് ഞാൻ എന്റെ എളിയ വാക്കുകൾ ഞാൻ നിർത്തുന്നു.
Thank you so much, Shahulka. This is M. Shahul Hamid, the chairman of All Kerala Colleges Alumni Forum. He's also a businessman. Thank you, Shahulka, for reminding our members to take the Aster Dilse package as well as the package that is announced now. Next, I would like to invite our president, Mr. Charles Paul. He is also an eminent businessman here, the president of All Kerala Colleges Alumni Forum. Mr. Charles.
Thank you, Anu. First of all, thank you so much for Aster volunteers for taking the initiative to conduct this type of informative webinars on various type of cancers. അക്കാഫിനെ സംബന്ധിച്ചിടത്തോളം ആസ്റ്ററുമായിട്ട് ചേർന്നിട്ടുള്ള ഒരു പാർട്ണർഷിപ്പ് വർഷങ്ങളായി തുടങ്ങിയിട്ട് ഒരു മെജസ്റ്റിക് പാർട്ണർഷിപ്പ് എന്നോ അല്ലെങ്കിൽ റോയൽ പാർട്ണർഷിപ്പ് എന്നൊക്കെ പറയാൻ പറ്റുന്ന ഒരു ഇത് തന്നെയാണ്. ഞങ്ങൾ തികച്ചും വി ആർ വെരി പ്രൗഡ് ഓഫ് ദിസ് ടൈപ്പ് ഓഫ് അസോസിയേഷൻസ്. ഇന്നിവിടെ നടന്ന ഈ ഒരു പ്രോഗ്രാമിൽ അക്കാഫിന്റെ അധികം ആളുകൾക്കും പങ്കെടുക്കാൻ സാധിച്ചിട്ടില്ല. കാരണം ടുഡേസ് വർക്കിംഗ് ഡേ, അതൊക്കെ ഒരു വലിയ പ്രശ്നം തന്നെയാണ്. എന്നിരുന്നാലും വളരെ ഇൻഫോർമേറ്റീവ് ആയിട്ടുള്ള ഒരു വെബിനാർ ആയിരുന്നു. എല്ലാ വേരിയസ് ടൈപ്പ് ഓഫ് ക്യാൻസറിനെ കുറിച്ചിട്ടൊക്കെ ഉള്ള ഒരു അവയർനെസ്സും ഇൻഫർമേഷനും ഒക്കെ എല്ലാവർക്കും കൊടുക്കാൻ സാധിച്ചു. ആസ്റ്ററെ സംബന്ധിച്ചിടത്തോളം പറയുകയാണെങ്കിൽ ഇന്ന് ലോകത്തെ ഏറ്റവും വലിയൊരു മെഡിക്കൽ ശൃംഖലയായിട്ട് മാറി വളരെ ഇൻഫോർമേറ്റീവ് ആയിട്ടുള്ള CSR പ്രവർത്തനങ്ങളും ഒക്കെ ആയിട്ട് മുമ്പോട്ട് പോകുമ്പോൾ ആസ്റ്ററുമായിട്ട് കൈകോർത്ത് നിന്ന് പ്രവർത്തിക്കാൻ സാധിക്കുന്നത് അക്കാഫിനും അക്കാഫിന്റെ മെമ്പേഴ്സിനും എന്നും ഒരു മുതൽക്കൂട്ട് തന്നെയാണ്. ഈ പറഞ്ഞ പാക്കേജസ് ഒക്കെ ഞങ്ങളുടെ മെമ്പേഴ്സിനെ കൊണ്ട് അവരെ അവയർനെസ് കൊടുക്കാനും അവരെ അതിന്റെ ഭാഗമാക്കാനും ഒക്കെ ഞങ്ങൾ മാക്സിമം ശ്രമിക്കുന്നതാണ്. ഇതൊക്കെ ശരിക്കും പറഞ്ഞു കഴിഞ്ഞാൽ വൺസ് ഇൻ എ ലൈഫ് കിട്ടുന്ന ഒരു വലിയ അപൂർവ സൗഭാഗ്യമായിട്ട് ഞങ്ങൾ കരുതുന്നു. ഇനിയും ആശ്രമമായിട്ടുള്ള എല്ലാ പ്രവർത്തനങ്ങളിലും കൂട്ടിച്ചേർന്ന് മുമ്പോട്ട് പോകുമ്പോൾ കൈകോർക്കുവാൻ തന്നെയാണ് ഞങ്ങളുടെയും ആഗ്രഹം. വളരെ സന്തോഷത്തോടുകൂടി പറയാൻ സാധിക്കുന്ന ഒരു കാര്യമുണ്ട്. ആശ്രമമായിട്ട് ചേർന്ന് ഞങ്ങൾ ചെയ്യുന്ന അതായത് ഈ മാസം അവസാനത്തോടെ മറ്റേ മൊബൈൽ ക്ലിനിക്ക് നോർത്തേൺ പാർട്സ് ഓഫ് കേരളയിൽ നമുക്കത് ഒത്തിരി പ്രവർത്തനങ്ങൾ ചെയ്യാൻ സാധിക്കുന്ന ഒരു മൊബൈൽ ക്ലിനിക്കിന്റെ ലോഞ്ച് മിക്കവാറും ഈ മാസം തന്നെ ചെയ്യാൻ സാധിക്കുമെന്നാണ് കരുതുന്നത്. ഇതൊക്കെ വലിയൊരു അഭിമാനത്തോടു കൂടി കാണുന്നു, സന്തോഷത്തോടു കൂടി കാണുന്നു. പ്രത്യേകിച്ച് ആ ഡോക്ടർ ആസാദ് മൂപ്പിന്റെ വളരെ ദീർഘവീക്ഷണത്തോടു കൂടിയുള്ള പ്രവർത്തനങ്ങളാണ് ആസ്റ്ററിനെ ഈ നിലയിൽ എത്തിച്ചതെന്ന് നമ്മൾക്കറിയാം. ഒരിക്കൽ കൂടി ആസ്റ്ററിന്റെ CSR പ്രവർത്തനങ്ങളുടെ ചുക്കാൻ പിടിക്കുന്ന വോളണ്ടിയേഴ്സിന്റെ നേതാവായിരിക്കുന്ന ഞങ്ങളുടെ എല്ലാവരുടെയും പ്രിയപ്പെട്ട, ഞങ്ങളുടെ തന്നെ ഒരു ഭാഗവുമാണെന്ന് വേണമെങ്കിൽ പറയാം, മിസ്റ്റർ ജലീലിനോടും എല്ലാവരോടും മറ്റുള്ളവരോടെല്ലാം എല്ലാവിധ നന്ദിയും കടപ്പാടും അറിയിച്ചുകൊണ്ട് നിർത്തട്ടെ. നന്ദി, നമസ്കാരം.
Thank you. Thank you so much, Charles, for those words. We are truly indebted to Aster. We've had a year-long association as part of the wellness campaign, and I've had the privilege of being closely associated with many of these people, and they're such wonderful people. A call away, they're all there to help us out, and we've been able to help a lot of our members. I would like to specially thank Mr. Jalil PA, a very close friend also, who has been the man behind all these things. Thank you so much, Jalilika, and of course, Nihad and Ritin and Vinu and the whole technical team who's always there to help us out, Siraj, everybody. Dr. Asad Mupan, of course, we cannot forget you. Thank you so much for this association with Akcaf. We will always be indebted to you, and we will always try to be a great support for you in spreading this awareness. Thank you so much for this evening. To all the doctors also who joined us on the panel, thank you for that information. This recording will probably be available for those who were not able to join our webinars. Please do take a listen, because you never know, some knowledge might save somebody's life. Thank you so much for joining in. Anup.
നന്ദി പറയാനുള്ളത് കൃത്യമായിട്ടുള്ള ഭാഷയിൽ ഞങ്ങളുടെ പ്രസിഡന്റും അനുവും ഷാഹുൽക്കൊക്കെ പറഞ്ഞു കഴിഞ്ഞെങ്കിലും അക്കാഫിന്റെ ഭാഗത്തു നിന്ന് കൃത്യമായി നിങ്ങളോട് എല്ലാവരോടും, ജലീലിക്കയോടൊന്നും മാത്രമല്ല ആസ്റ്ററിനോട് നമ്മൾ ഒരുപാട് കടപ്പെട്ടിരിക്കുന്നു. കാരണം കഴിഞ്ഞ കുറെ വർഷങ്ങളായിട്ട് അവർ ചെയ്തു തന്ന, ഇന്നത്തെ ഒരു വെബിനാറിന് മാത്രമല്ല, കുറെ വർഷങ്ങളായിട്ട് നമ്മുടെ അക്കാഫിലെ ഓരോ സുഹൃത്തുക്കൾക്കും വേണ്ടി ചെയ്തു തന്നിട്ടുള്ള ഒരുപാട് കാര്യങ്ങൾക്ക് കൂടെ നമ്മൾ ഈ അവസരത്തിൽ നന്ദി പറയുകയാണ്. ഇനിയും എപ്പോഴും നിങ്ങൾ അവൈലബിൾ ആയിരിക്കുമെന്ന് ഞങ്ങൾക്കറിയാം, എങ്കിലും അതിനു കൂടെ ചേർത്ത് നന്ദി പറയുന്നു. പിന്നെ ഇന്ന് നിങ്ങൾ സൃഷ്ടിച്ചത് ഒരു മായാ പ്രപഞ്ചമാണ്. കാരണം എന്നുണ്ടെങ്കിൽ നമ്മൾക്കറിയാം, നമ്മളെല്ലാവരും ഒരുപാട് തിരക്കുള്ള മനുഷ്യരാണ് പ്രവാസ ലോകത്ത്. അപ്പോൾ നമ്മൾ ഒരിക്കലും അന്വേഷിക്കാത്തത് നമ്മുടെ സ്വന്തം ആരോഗ്യമാണ്. അതിൽ തന്നെ ക്യാൻസർ കാരണം നിന്ന ഒരുപാട് മനുഷ്യർ നമ്മുടെ കൂട്ടത്തിൽ ഇപ്പോഴും ഉണ്ടായേക്കാം, ഇനിയും ഉണ്ടാവാം. അത് തടയാൻ, നമ്മുടെ കൂട്ടത്തിൽ ഇനിയും ഒരു അശ്രദ്ധ ഉണ്ടാകാതിരിക്കാൻ നിങ്ങൾ ഓരോരുത്തരും ഇവരുടെ വാക്കുകൾ ശിരസാവഹിക്കുക, ആസ്റ്ററിനെ സമീപിക്കുക. നമ്മൾക്ക് ഒരുമിച്ച് നിൽക്കാം. നമ്മൾക്ക് എല്ലാ കാലത്തും കഴിയും വിധം നമുക്ക് എല്ലാവർക്കും ഒരു തവണ തിരിച്ചു പോകേണ്ടതാണ്. പക്ഷെ എങ്കിലും അതിനു മുൻപ് അതിന് അനാവശ്യമായ ഒരു സാഹചര്യം സൃഷ്ടിക്കാതെ നമ്മൾ ഒരുമിച്ച് നിൽക്കണം, ആസ്റ്ററിനൊപ്പം നിൽക്കണം. ഇത് മുഴുവൻ കേൾക്കണം. അക്കാഫും ആസ്റ്ററും നിങ്ങൾക്കൊപ്പം ഉണ്ടാവും. നന്ദി.
Thank you so much, Ms. Anu and Mr. Anup. I think there's nothing more that I can say, but thank you for everyone who were here today, for your time and attention to this very critical part of early detection and prevention. Please note that this webinar is available on both Aster volunteers as well as the Aster DM Facebook pages and our social media handles. If you'd like to go back and look at certain things that you'd like to look at, or if you've missed this session, I would urge you to go ahead and take a look at our panelists talking to us about cancer. Thank you very much. Signing off, Dr. Spetika from Aster.